poster on the counter. It's in that little gray.
Oh. There it is. Oh, okay, gotcha.
Okay.
It said once you get your hands on it, I'll go backward.
I'm not hearing anything.
John Comerford here.
Good morning, Lou. This is Tom McRobert. I just heard John Comerford's voice, but that's the only thing I've heard.
Hi, Tom.
Morning, John and Tom. I think it takes a while before they turn the sound on in the room because I think once they do that, they start recording.
Okay, thank you.
Thank you. Lou looks smaller on television.
Yeah, he's screen shrunk.
Yeah.
And we're great. All right, folks, this meeting's come to order. Good morning and welcome. This is our second June PEB board meeting of the season. Our meeting this year will continue to be hybrid. HCA staff will be on site, board members and other attendees will have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide is information about how attendees can turn on closed captioning. Board member intros. Elliot.
Here.
That's not your home system here. There you
Here.
go. There you go. Harry. Here. Kurt. Here. Sharon. Here. Michaela.
Present.
Well, she had to change it up, didn't you? John.
Here.
And Tom.
Here.
And from the AD's office, Michael Tunick. Present. All right. And I'm Lou McDermott. I'm filling in for Sue Birch, I believe, for the remainder of the season as well, today and the remainder of the season. I'm the Deputy Director here at the Healthcare Authority. With board members attending both in person and virtually, it's really helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks for questions. Board members attending virtually, we're going to be watching for your Zoom hand to indicate you have a question. There's going to be a few resolutions scheduled for action today, so the public's going to have an opportunity to provide comments on those specific resolutions during normal procedure before the board votes, and the public's going to have the public comment period at the end as well. As a reminder, if the public has questions during staff presentations, the presenter's contact information is going to be included at the end of the presentation, and you're welcome to email the presenters during the meeting to capture your question or response. Dave, what do we got going on today?
Good morning, Chairman Durbin, members of the board. Today, we are going to start with a brief executive session. So we will have to ask members of the public in person to step outside for a few minutes. We just have a couple of rate setting things to inform the board about that are part of the proprietary information on the rate development process. So we do have a short executive session at the beginning of the meeting. Then I have a little bit of follow-up on some of the pharmacy questions and some information that people wanted to access links and to be able to leverage some of the online systems that members can use related to pharmacy. John Parton is bringing back the resolution and topic related to that we've been talking about with kind of auto and home insurance and criteria for evaluating those type of insurance product lines, and I'm hoping that you'll take action on that today. Then Beth will come forward, Beth Heston, to talk through the annual procurement, which really is the embodiment of the work that is done that can result in benefit changes that then are rolled into and lead towards the final premiums. Tanya will join us and present the non-Medicare rates for both retirees and employees for 2025. And then we will turn our focus to the Medicare side of the house again. And Stella will come back and bring a couple of resolutions related to international coverage that were introduced at the last meeting related to the transition of UMP Part to Part D plan for the pharmacy coverage. And then as we work through lunch, Ellen will be back to talk through a couple of topics in general in the portfolio for Medicare. And then Molly Christie will unveil the rates that we have been working on related to the Medicare side of the house and the impacts of the board's decision to shift to the Part D formulary and what the world would have looked like if that decision hadn't been made for 2025 and what the world actually looks like because that decision was made earlier this year. Then, as hard as it can be believed, since it's only June, I'll be talking about the 2025 board meeting schedule for the board. And so that's what we're going through today. I do want to remind everyone that if there is an emergency, we're going to walk purposefully. We're not going to run, we're not going to dawdle, but we're going to walk purposefully across the street into the parking lot area. And similarly, if you need to use the restroom, walk purposely down the hall and look to the left, you'll see the restrooms. And with that, Chair McDermott, I turn it back to you.
All right, thank you. We're going to be voting on the meeting minutes from the last board meeting on June 13th. They're behind tab number 3. Do we have any comments from the board? Seeing none, do I have a motion to approve the minutes?
So moved.
Second. And there's a second. All in favor say aye.
Aye.
Any opposed? Hearing none, the June 13th, 2024 minutes are approved as written. And now, executive session, is that correct? All right, we're going to be transitioning to executive session, which happens here in the Sue Crystal room for board members and including HCA employees at this time, members of the public joining us in person, the Healthcare Authority, as well as employees not part of the executive session are going to be asked to be in the main lobby for the duration of our executive session. You'll be called back to join us in Sue Crystal for the remainder of the public meeting after executive session is concluded. So pursuant to RCW 42.30.110 subsection 1L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 4105.26. The executive session will conclude no later than 9:45. Board members, let's take a quick break while we transition to executive session. Thank you.
And for members of the public, we may not be in executive session for the full 20 minutes, so I would encourage you not to go too far from your remote centers as we may be back sooner.
I was waiting for the recording to start. It doesn't announce it. Oh my God.
Evidently later we'll be talking about hearing.
My name got tested and I'm right below the threshold. They're like, you're fine, Phil. I'm like, oh.
Second opinion.
Second. All right, folks, we're back from executive session. We're going to get a follow-up on the June 13th meeting. Dave is going to bring back some requested information regarding pharmacy administration from our last board meeting. His materials behind tab number 4. Dave.
Good morning, Chair McDermott, members of the board again. Last meeting, I learned that I need to always account for more time for pharmacy presentations than I think. I think I need to average 4 minutes a slide instead of 3 minutes a slide. But as part of that meeting presentation, Jenny and Ryan brought a lot of good information. One of the questions that was asked for follow-up and is in these slides were various links and phone numbers for some of the tools that have been described by Jenny and Ryan. So on slide number 2, we've talked about the pharmacy locator tool for being able to identify network pharmacies. And so that tool, the link here is from Navitus, which is the subcontractor of MODA that is really doing some of those core service point and network aspects of the pharmacy benefit. That link is here, and also the general number for MODA customer service. I think it's important to remind people that as we move forward, there will likely be, especially in the Medicare side of the house, you will get 2 insurance cards. There'll be one for medical and one for pharmacy, and you'll have more of these numbers will be more apparent, and it won't be like which number of the 5 numbers that are on the back of the card do I call for pharmacy. You'll look at your pharmacy card and call the pharmacy numbers. But this is just the general number that we have for our customer support with MODA. The next slide, number 3, has some of those drug price check tools. So I think we're all unfortunately familiar with, you can pick up pill A at pharmacy 1 and pharmacy 2, and it's the same pill and the same prescription, but with a different out-of-pocket cost. And so the price checker tools are things that you do not have to be a member of UNP to access these links. These are generally available regardless. There's not a portal that you need to sign in with your own number. So this is something that if anybody's just wants to understand the general dynamics, where they're thinking about switching to UNP, or they just want to understand, is one pharmacy that for some reason always more than another pharmacy as they're picking where they want to get their prescription filled, anyone can use this tool. Even people who aren't PEB members, a general member of the public can just look at these particular links and do price check tools. So this was just me bringing back various links so that people can forward them around, be able to access them, and make sure, there's this question, I think, Elliot, that you asked last time, that many people think that this formulary is all secret. And I was like, it's not secret, it's on everybody's website. And so this was just to come back and say, yep, it's not secret, here's where you go look. So
Thank you very
yeah.
much.
So that's all I had as follow-up, was just to bring these particular pieces back, and wanted to see if there's any other questions about this. Any questions for Dave? All right, seeing none. Mr. Park.
John Parton, Benefit Strategy and Design Section Manager in the IRB Division. Resolution for voting today related to the property casualty insurance benefit and evaluation criteria for future possible benefits is materials behind tab number 5. And after John reviews the resolution, I'm going to ask for a motion to adopt. The second, we're going to go with public comment, and then we're going to ask the board for discussion until we're ready to vote. Welcome, John.
Thank you, Chair McDermott, members of the board. Good to be back, bringing back something we talked about a few weeks ago. As you all recall, there's a piece of the revised code which gives the board the ability to offer property casualty accident insurance through a payroll deduction plan, and we have one grandfather plan currently that fits this, and we're just looking to adopt criteria for evaluating these moving forward. So we made a couple of changes based on feedback we received from the board. Didn't receive any other feedback separately. So the 2 changes, one shows here, and most of these are marked revised, and it's for the same reason. This is simply adding the reference to the subsection 9, which was called out, to make sure that we weren't unintentionally or intentionally expanding the application of these criteria to other, or this opportunity for coverage to other features or benefits. So that's the only change here, is adding the reference to subsection 9. And if we move to the next slide. This is the one that had a substantive change in terms of the word that we use to describe the changes in access that might be offered by a plan. And it was called out that improved is somewhat nebulous, difficult to measure and quantify, whereas equitable is a little bit more defined and easy to demonstrate in the way that we position things for the board to review. We bring them to you for your review and ultimate approval. So that's the major change here. And then if we go to the next slide, again, only change here is calling out that this is applicable to subsection 9, and the same on the next slide. I'm sorry, if you go back one slide, there was a removal of the reference to the RCW that applies only to the SEP board. And then if we move to the next, again, just calling out subsection 9. And next slide. Same thing, except we're changing the date, obviously, as we won't refer back to June 13th as it was shown in this set of criteria with the revisions from this meeting. And then the actual resolution, which again is changed only in terms of adding the resolve that language and the date of the reference to the criteria. So I'll hand it back to Chairman Turner.
Any questions for John before we get started? All right, we're gonna take a vote on resolution PEB 24-25, evaluating criteria for contracts under RCW 4105-065 subsection 9. Resolve that the provision of property casualty and accident insurance plans and related evaluation criteria in prior board policy discussions and resolutions is repeated and replaced with the following. The board adopts an evaluation criteria as presented at the June 27, 2024 board meeting, by which it shall evaluate contracts considered under RCW 4105-065 subsection 9 as applicable. Is there a motion to adopt?
So move.
Is there a second?
Second.
All right.
Second.
Any comments from the public? Kenzie? Seeing none, any comments from the board? Seeing none, can we have roll call vote starting with Elliot?
Aye.
Perry? Aye. Kurt? Aye. Sharon?
Aye.
Kyla?
Aye.
Tom?
Aye.
And Lou, aye. Resolution 24-25 passes. Thank you. Next steps, John?
We'll work on implementing this and starting to apply it, particularly for the contract renewal with the one existing grandfather arrangement for Liberty Mutual. So appreciate the board's attention.
Awesome. Thanks, John.
Thank you.
Beth Heston, come on down. Beth is our procurement manager in PEBB, and she's going to be providing us with an update on the annual procurement work with carriers that help inform benefit changes and ultimately next year's member monthly premiums. Her materials behind tab number 16. Welcome, Beth.
Welcome. Thank you, Chairman. Members of the board, as Lou said, I'm Beth Heston. I'm the PEB procurement manager, and we want to talk today about the changes that are coming from paying year 2025 as a result of this year's renewal. Next slide, please. Just a reminder of our timeline. The release of the RFR, request for renewal, went out at the end of February. It was responded to in two stages. First, in April, we got back benefit changes, and then at the 1st of May, we got back bid rates. During the rest of May and June, we have negotiated with our partner carriers, and we have shared some benefit changes with you. We are going to publicly announce those today, and then in July, the rates will be voted on by the board. Next slide. So the first, the overview today is we have changes to all plans related to the IRS consumer-directed health plans. We also then we're going to go over the changes for Kaiser Foundation Health Plan of the Northwest. We're then going to talk about the Kaiser Foundation Plan of Washington, and finally we'll go over the Uniform Medical Plan changes. Next slide. The IRS earlier this year changed the changed the amount of the minimum out of pocket with CDHP plans. They raised it by $50. This has happened in previous years. The board voted back in 2023 to allow us to change that floor of minimum deductible without a board resolution vote. So we are raising it. It'll be $1,650, and for a family, it'll be $3,300 going into 2025.
Just one refinement, you said out of pocket maximum, but you meant deductible.
Sorry. Yes, I meant deductible, minimum.
So we won't go through it in as detail every time and include the resolution year over year, but this first year, bringing it back to the board and the public, just wanted to remind you that, we're essentially at this point where we're chasing the minimum requirement to make sure that members who enroll this plan can continue to take advantage of the tax preferred dollar aspect that goes with this plan. And last year, the board again voted on a resolution to say the agency should just chase the deductible minimum rather than bringing you a resolution year over year to raise the deductible, which I know is always a difficult conversation to have in of itself. And so just appreciate again the kind of streamlining this for the future. And we've said that we will continue to bring back to the board year over year. When the IRS does make these changes, they don't do it every year, but they do it most years. Whenever that happens, we'll just provide you that information and remind you that we're chasing that minimum requirement by the IRS now.
And it's often only a $50 increase. So, next slide, please. We're going to talk next about Kaiser Foundation Health Plan of the Northwest, KPNW. Next. And just a reminder, KPNW only operates in Clark and Cowlitz counties in the southern part of Washington. They also cover counties in Oregon where we have members. The first changes that are going to go through for KPNW are state mandates on asthma inhalers and EpiPens. The state voted the legislature voted to cap the out-of-pocket maximum cost for a 30-day supply of inhalers at $35. That also includes EpiPens. And so the change is at least one inhaled corticosteroid and one inhaled corticosteroid combination product, and at least 2 epinephrine auto-injectors containing at least 2 auto-injectors for $35. Then we have the state mandate increasing access to human immunodeficiency virus post-exposure prophylaxis, PEB, drugs and therapy. Starting with 2025 plan year, the mandate prohibits health plans and Medicaid from imposing cost sharing or prior authorization requirements for at least one full PEP regimen. Shifting over to Kaiser Foundation Health Plan of Washington.
Real quick, Beth, as you're about to go through this, I often say that half of my job is repeating myself and the other half of my job is repeating myself. So if this sounds familiar at this point in the year with the number of board meetings and executive sessions, I can't remember if I've said this, so I'm just going to say it again out of caution. There are really 3 types of benefit changes that Beth can describe in these presentations, and you're about to see all 3 versions of that in the Kaiser Washington part of the portfolio. First is what we call the state mandate bucket, which are things that the legislature has passed and the governor has signed that become requirements either in the PEB program specifically or among the commercial market in general. And so those are things that the carriers and Uniform Medical Plan, when it says again, have to implement. The second bucket comes, most often we see in the Kaiser portfolio, it could be in the Northwest region or the Washington region. We call them book of business changes. And so those are things that Kaiser is bringing forward and saying across their entire commercial portfolio in the region, they are making a change to all of their products, not just in PEB, but also in SEB and also outside in the other offerings that they have in the commercial market. And so those are things that are, when they are bidding their product, they are saying, this is part of the package. There's not discretion to carve that out or have something different for PEB. It is part of the package of offerings that they are offering up for the year. If something that is in a book of business change is so unpalatable or concerning to the board, your option would be to not authorize the plan. You wouldn't be able to carve that piece out, object to that specific component. There's really not, it's an up or down vote on those types of changes because it is inherent to how they are operating in the Washington market. And then the third bucket is where there is discretion. The board can say, yes, I want to include this. No, I don't want to include this. And they are kind of PEB specific parts of our portfolio. So there's the state mandate bucket, there's the book of business bucket, and neither of those really have discretion. And then there's the kind of optional tailored aspects of the plan. So I just wanted to go through those three types and distinguish them in the language that Beth uses on her slides and in the titles. And Elliot, you have a question?
What will be helpful, I think, in the future when those situations come up? I'm not sure I know enough to know this is discretionary, this is the second bucket. I need to know, I can only speak for myself. I need to know which bucket we're looking at. It's not inherently obvious to me.
Yeah, I think Elliot, something that can help with that is this season I've been saying what I just said and
Yeah.
repeating myself in various forums on that piece. And we use that language in the headers of our slides, but I think it might be helpful for us in the future to put a slide itself that describes what those headers mean so that you can look at the slide deck later and go, oh, that's what a state mandate means. That's what a book of business means. That's what this phrase means. So we can work on that in the future.
I will also add that some of us learn by hearing. I'm one of those. Some of us learn better by seeing. It depends, and some of us are contact. They have to kinetic learners. And so for me, I can only speak for myself. I learn better when I hear your charming voice.
I've been told I like to interject, so I'm glad that that helps. And at the same time, we often think of our slide decks as hopefully people can look at them after the fact and not have to listen to the audio. And so as I was just saying the description of the headers, it made me think, oh, we should look at putting those kind of definitions in a slide deck. And then Beth's voice can highlight them as part of standard instead of me jumping in. So
Not nearly so charming.
well, I'm going to hand it back over to Beth now.
Okay, so these changes are for Kaiser Foundation Health Plan of Washington. Next slide, please. The first are the same state mandated changes that I spoke about with Kaiser Northwest. Inhalers and epinephrine injectors, auto injectors, and the PEB drugs for therapies. Next slide. This is the first of our book of business changes. These are changes, as Dave said, across the entire book of business. And the first of those is a change to advanced care at home. This was a program that was implemented and promoted in 2023 that allowed certain patients to be discharged from the hospital and receive follow-up care either in their home or by being brought back to the hospital briefly for the treatment and then returned home. Kaiser is removing this service. They are keeping the portion where members will be released early, and they will still have access to services at home via their care providers. It just will depend on which services they need. Also, planned cost shares for inpatient, outpatient pharmacy will apply, which they have not done before. The key change is that cost shares were waived up till this point. So it's, while they're retiring the program, it will still operate as, you know, sort of their practice. But now the members have to pay their own cost shares. So, yeah.
So the reason why they're sunsetting this is that there still must be need, especially for older adults with multiple conditions. So what is it? Cost? What's the reason?
I believe that it's just not making it a special program. It's becoming more of a standard practice.
Okay.
Because people who are released early from the hospital are removed from spaces where they can get post-operation infections and that sort of thing. So it takes them out of the environment. It also increases their ability to rest and recuperate because they're not in a strange environment. They're sleeping in their own bed. And if they do have to have follow-up, they get it from care providers who come to their home. It's, I think the main difference is it's not a special program anymore. And when possible, care providers will still be visiting these people at home. So, and the difference, of course, is that they will have to pay their regular cost shares.
Another question, 'cause that's really quite interesting. So what about some of those people who are care providers for them in their home, like family members who are care providers? Are they given additional supports, given that this is being waived now?
I think it's care providers who are not the home care. This is more clinical care providers, like doctors and nurses who visit the person at home. All right, slide 10. This is a book of business change for non-Medicare members concerning end-stage renal disease. Individuals who have end-stage renal disease qualify for Medicare after a 90-day waiting period. Once an ESRD member becomes eligible for Medicare, TP Washington may add coverage that would include waiving cost shares and reimbursing members for the cost of the standard Medicare Part D monthly premium.
I'll add a little bit more context on this one, because this one is a little bit counterintuitive to people, because many people in the insurance and payer world are very aware that you can't, it's a general rule from CMS, you can't incentivize being on Medicare coverage and cost shifting over to the Medicare Trust Fund. And so this seems counter to that. This is one of the only real exceptions that is kind of widely practiced, understood, and accepted. And it's about kind of smoothing that transition for people, because there is that 90-day waiting period. And so as people have got this diagnosis and are moving into end-stage renal disease, it's finding a way to help them in that transitory process. Some people may be reticent or apprehensive about kind of going forward in that process because they have this period that they need to wait, but this helps smooth out that experience for them. It is something that because ultimately then those individuals have Medicare as their primary coverage for these benefits, it ends up helping to plan that is no longer primary coverage have savings at some point. But this is a very long ramp for being able to kind of book or estimate those savings. It's something that is in a 2, 3, even 4-year outlook. There's an 18-month period of in the claims process and transition that happens. So it's not something that has immediate dividends, if you will, but it is very member friendly. It's a common practice, and it's something that Kaiser is kind of rolling out across their book of business in the state.
The word "may" is key in here, assuming that they would have some sort of methodology to determine, maybe they run out of money in some way, or say, we can't do this anymore from our budgeting perspective. But that I think is kind of a question I had. Do they share their process for how they evaluate? Who may or may not, get that help?
That's a great question, Harry. I don't know that we have the immediate answer here, but we have one more meeting before we ask you to vote, and we'll bring that back as a follow-up to help understand the use of the word "may" right there.
I was great minds think alike. I had the same exact question.
Scare me now.
Okay, now he's bummed out. I think the employees need to know what the criteria are. And the other concern I have is, if you have end-stage renal disease, how are you supposed to negotiate all of these different hurdles? That's a pretty severe medical state.
And I think that this program is meant to help smooth that barrier for them, because they're busy with their treatment, they're in dialysis, and moving them to Medicare helps, encourages them to make the change, because it can be financially beneficial, and the plan will be assisting at any place they can.
I would just personally, I don't know if I'm speaking for others. I would like to know some more. It's not about your presentation. It's about the company being more specific on the hurdles that they have to overcome.
Yes, and our Kaiser representatives are here with us today, and they're hearing your question directly, and so we definitely will have more information for you at our next meeting.
Yeah, it might help if they had a number to call, some things where they can ask questions.
We will definitely follow up on that. I have ideas, but now's not the time to guess. We have time to follow up, so we will follow up.
Thank you. All right, and one last comment about book of business changes. This one we just learned of this past week, so we don't have a slide, but Tanya will include it in her rate presentation next month. I'm just going to tell you about it today. Kaiser offers several different wellness/mental health apps for their members to use. They use Calm. Many of you have probably seen that advertised different places. They also use one called Carrot, which is a strange name, but that was the name of it. They also have one called Headspace Care. The primary one that has been there the longest is called My Strength. They are now ending that self-care app. They're not renewing the contract. The name has changed to Teladoc Health. It will end on July 31st this year. And as of August 1st, no new registrations can take place. But members who are currently using it can use it for the rest of the plan year. So they can use it through the end of the year. But Kaiser is encouraging members to switch to one of the other apps, such as Calm or Headspace Care. And Calm is available to members aged 13 and up. And Headspace Care is available to ages 18 and up. So there are other choices for them to move through. So we just wanted to let you know about that one.
As I understand it, some of this is about some of the duplicative aspect of the suite of offerings that Kaiser is leveraging for this. And, I think all of us are used to looking at where, one of the buzzwords in insurance and healthcare is administrative simplification. And when you think about duplicative things, so this is just, it's not that they won't have resources available. They're just centralizing from 4 apps to 3 apps, so to speak. And this is just part of that natural subcontractor renewal that's happening there. And they're just trying to simplify the process and not have duplicative resources for the folks to navigate. Elliot?
So given your mini tutorial, which was very helpful, these book of business changes are endemic to Kaiser, and they cannot be changed without rejecting the plan.
That is correct, Elliot, yes.
All right, so moving on to uniform medical plan changes. Next slide. We have the same federal mandate, which was to increase the deductible minimum on the CDHP. Like Kaiser, Uniform Medical will be adding the caps on the inhalers and epinephrine auto injectors. They will also be increasing access to the HIV post-exposure prophylaxis or PEB drugs, just like the other plans. Next slide. If you'll recall, at the May meeting, a resolution was passed to eliminate cost sharing for diagnostic and supplemental breast exams. So beginning January 1st, those breast exams will be covered with no cost share. High deductible or CDHP plan members have to meet their deductible before it will be paid in full. Next slide. We also have some changes to the UMP Plus service areas. Puget Sound High Value Network will no longer be in Chelan or Douglas County in 2025. The Plus networks have until June 30th to notify us of their plan changes. They've received we have received notice that Confluence Health is leaving Puget Sound High Value Network for 2025. And so Puget Sound High Value Network will withdraw from Chelan and Douglas counties.
So just a quick reminder for everybody about UMP Plus. This is where we have our coordinated network within the network. So, UMP is a broad-based PPO, preferred provider organization, and kind of have a very wide range, and it's kind of up to the member to kind of coordinate their care generally in a PPO amongst the various primary care and specialty providers. And in the UMP Plus, there's this network within the network that also part of its role is to help you coordinate care across its various partners, hospital provider systems. So there are large hospitals, provider networks that have partnered together in these entities, Puget Sound High Value Network and UW Medicine Accountable Care Network. And at any given year, partner provider, if you will, one of the large systems may exit the arrangement with their fellow partners. And in this instance, what we have received notice of is that Confluence is leaving. They are the primary medical provider system within the Douglas-Chelan County area, so that there is not truly like network adequacy for the UMP Plus network. Confluence is still a member of the Uniform Medical Plan's broad-based PPO network. So the way to think of it is there is still a contract between Regents and Confluence for the general Uniform Plan book of business. They're just not part of the sub-network for this specific plan type. So that means all of these members who are at Confluence, they're not losing access to Confluence, they're losing access to this specific plan within the suite of offerings of UMP. These members will still be able to enroll in UMP Classic, UMP Select, or UMP CDHP. So they still will have access to UMP, just not this specific network arrangement, which includes the option for a lower deductible and some primary care visits with no cost share. That's essentially what they're losing in this instance. So there will be outreach like there is anytime this is not the first network change that we've had in UMP Plus since 2016, I think it is. But so we have experience in helping people transition whenever something changes within this network, and we'll activate those measures. But just wanted to reassure people that it's not that UMP doesn't exist in Chelan Douglas County. It's just this fourth plan that's in the suite of offerings won't be available to them. And at this point, although June 30th is this Sunday, we've heard from the networks that there aren't any other potential changes that are in the works potentially.
Next slide, please. Just to give you some numbers, there are around 1,000 members who will be affected by this change. The members will, as Dave said, have the other UMP plans to choose from. There are 514 total PEB members who will be affected. 321 of those are in Chelan County and 193 are in Douglas County. Our SEB sister plan or sister program will also be losing coverage for about 331 members in Chelan County and 237 members in Douglas.
And Beth, I'm assuming if they don't make a positive change in the system in 24/7, then we'll automatically move them.
I believe so.
That is correct. And we have so many different service area changes happening between portfolios that I'm not going to promise what plan it is, but we often do a mapping exercise to see what is the most comparable plan. And the plan that is most often used as the automatic enrollment plan in PEB is UMP Classic. But if there's something on plan design that is more similar, that is one of the other UMP offerings, it may be a different offering. So most likely it will be UMP Classic. We're just doing a mapping exercise for a variety of service changes that are happening between the two portfolios. And I'm afraid I'm going to say the wrong plan name, but typically in PEB it'll be UMP Classic. But yes, they will be put into coverage. They won't be put into waiver status. That the core policy of both programs is you are defaulted or automatically enrolled into coverage if you don't have it.
And one last thing, they're going to be sent a letter saying, hey, this is happening. Okay,
right.
Understood.
That is correct.
It was pretty
understanding that providers come and go. But this is pretty significant number. Do we have a reason? I mean, what's going else? Payment plan? Is there a way to describe that? It's not too detailed.
Let me do my best shot at it. That in the accountable care space, there are really these entities that are really kind of, like I said, they're usually spearheaded by one provider system, and then they're contracting with other provider systems to kind of build this network. They can have a wide range of financial arrangements, and we're not really privy to what those exact financial arrangements are. When they come to the healthcare authority, at least I can speak to this from the UMP plus 8 accountable care program perspective, we have a specific target that they have to meet, but then how they subdivide that across their partner networks really is up to that. In this instance, Unified Health Value Network or UW Accountable Care Network. We don't know how they subdivide that, but each provider network that is partnering within those arrangements is always assessing that financial arrangement that they have overall. And while I can't speak to exactly what the dynamic is here, it's typically something around what, it's looking at the financial aspect of the arrangement that they have and whether it makes more sense to be in or out and be just part of the broader PPO network within UMP or the other pieces. But it's really about that direct financial arrangement that those provider groups have come up with together and what they think is best for their hospital system. So
if I may follow up question, and that was my question too about the level of communication about this change, especially communicating the other plan offers that they do not, the benefits of those. If it, again, I hope that that's clear for the members to know that they're not losing maybe specificity in the specific levels, but overall, and that they do have that option to choose really needs to be there, especially in these counties. I feel that folks that more rural communities that may not, I just feel that there needs to be much more clarity. But there's this kind of a change and to a clarity in terms of what their choices will be as a follow-up as well.
yeah, we definitely do have written communications that will go out. There will also be summaries in the general newsletter about service area changes that are happening. But we do have a fair amount of experience with changes in the plus networks. I think the hardest one was when one county's service area switched between the two networks. And so everyone had to affirmatively switch from High Value Network to UW in Spokane County, unless if they didn't, they were put in Classic. It's very rare, but the partner provider switched legal entities. And so we had to help people respond and understand that. That was a fun one. That's actually was harder than this piece of it, but we do have this experience in helping people understand what those choices are that they have. I do think a key message here is to make sure that people know you still can go to Confluence. When you're in a rural area and it's the major or only player in town, you might be more worried, and we have to reassure people that leaving this particular plan isn't leaving UMP.
So just two things. This won't affect members on the 1st of July, correct?
Correct. This is effective January 1st, 2025.
So, but this wouldn't then qualify as a special open enrollment. Or remember, if for some reason they wanted to leave 1st of July.
Correct. This does, since the change to the network, yeah, this does not qualify as a mid-year special open enrollment event. The network today, June 27th, is the same on July 1st. It's the same all the way through December 31st of this year. The change is for 2025, which is why it's emphasized, and the change that a member would need to make needs to happen during the annual open enrollment in the fall, which are the changes that go into effect for the next plan year in January. I saw Elliot's light at one point, and I think I saw Kurt's light at one point. So I just want to make sure if there's other questions.
Just probably already said this, but just confirming. Those 1,000 members will have to switch from UMP Plus to UMP Classic to continue to go to Confluence.
Or UMP Select, or UMP, one of the other three UMP plans.
Gotcha.
And the 1,000 members is the totality of PEB and SEB. I did want to make sure it's clear that's not 1,000 for PEB. Beth gave the breakdown. It's a little over 50-50. It's a little bit more PEB heavy than it is SEB heavy, but that's a total number between the two programs.
That's total members, including family members, not just subscribers.
Correct. That's members, not subscribers. It includes dependents.
Got it.
Yeah, 514 are PEB and the rest are SEB.
Okay, so it is about 50. I think, like I said with Yogi Berra, half of my job is repeating myself, and the other half of my job is repeating myself. So I'm used to that. Are there any questions online? Okay, go with that.
Moving to questions.
It always seems to go that way. You answer a bunch of questions. Next slide. Questions? Does anyone have follow-up questions? No. Beth, thank you so much. Appreciate it. Next up, Tanya Jewell, our finance manager in the FSD division. This is going to be introducing the 2025 PEB program non-Medicare premiums that will be up for voting at our next meeting on July 11th. No action scheduled on the resolution today. Our materials behind tab number 7. Tanya, welcome.
Thanks, Chair McDermott, members of the board. I am going to walk today through the 2025 non-Medicare premiums, which is both employees and our non-Medicare retirees. Medicare premiums will be in a separate presentation later today. All right, first up, we're going to focus on employee premiums first. And as part of that, we are going to do a walkthrough of how the employer medical contribution, known as the EMC, is calculated. This is defined in the collective bargaining agreement and bargained every other year. And we follow the methodology that's outlined in the agreement. So this is a sample calculation on the screen, and then we'll get into the actual number in a couple slides. How the employer's contribution is calculated is benchmarked off of UMP Classic. So we look at the UMP Classic bid rate, which for this example is $800. We multiply that by 85% to determine the EMC, which in this example is $680. We then subtract that $680 from the $800 Classic bid rate to determine the employee premium in this scenario of $120. We then follow that logic through each of the plan bid rates. And in this example, we have 3 bid rates ranging from $700 to $800. You can see across the top in those A, B, and C plan bid rates. So regardless of the total bid rate cost, the employer medical contribution of $680 is subtracted. So if an employee chooses to pick a more expensive plan, like in this example, Plan C, the employee will pay the difference of $120, or if they choose to enroll in a lower price point plan of $700, like Plan A, we subtract that same $680, and the employee would pay the difference of $20. We then take that same logic and we apply it to both the employer's contribution and the employee's contribution. Both of those numbers get multiplied by the following tier factors here. So tier 1 is just what we walked through, which is just the subscriber only. It's multiplied, just by 1. And then we have our tier 2, which is the subscriber and spouse or state registered domestic partner. And we multiply that rate by 2. We have our tier 3, which is the subscriber and child or children. So regardless of the number of children on the account, it is multiplied by 1.75. So if you have 1 child, get that extra 0.75, or if you have 5 children, that same 0.75 credit. And then on tier 4, which is the subscriber and spouse or state registered domestic partner and child or children, it's multiplied by 2.75. And again, that's both for the EMC and the premiums. This does not account for any surcharges also that may be assessed to the employees. So on the next slide here, we're going to walk through the proposed 2025 employee premiums for both employer and employee. How this slide is set up is by carrier. So you'll see 3 separate sets of rates. So at the top, you'll see Kaiser Northwest for both of their plan offerings, followed by Kaiser Washington, and then the Uniform Medical Plan. That first column on the left in the darker blue is the total bid rates. These are the actual bid rates that were bid and negotiated with our carriers. For the Uniform Medical Plan, again, those are developed by us in consultation with our actuaries.
And Tanya, by us, we mean the healthcare
HCA,
authority, not Regents and Moda.
Yes, Regents and Moda do not develop our rates for us. That middle column is the actual employer medical contribution for 2025 at $759. As you can see, this is the same for all of the plans regardless of the total bid rate. This is an increase from last year, which was $702 last year. So when you take the total bid rate on the left, you subtract the employer contribution in the middle, you get the employee contribution on the far right. Next slide is where we'll spend a little bit more time. Again, this is sorted in the same order by carrier, starting with Kaiser Northwest, Kaiser Washington, and then the Uniform Medical Plan. But what is on this is a comparison of the 2024 employee premiums for that single subscriber compared to the proposed 2025. So when you take 2024 versus 25, The next two columns are the year-over-year change in terms of dollars and percentages. We also included some member enrollment counts on the far right, so you can see of the total population, which percentage of our enrollment is in which plans. Pointing out UMP Classic has over 50% of the total population enrolled. So last year, I'm sure we all remember there were some really difficult conversations around the increases with some of the Kaiser premiums. This year, you're going to notice, I think someone advanced the slides. Thank you. You'll notice on the Kaiser premiums here, largely all of the employees are going to experience a decrease going into 2025. This is largely due to Kaiser having a more favorable outlook on their trends for their 2025 rates than they had in their 2024 rate development, as well as some of the impact of switching that impacts the mechanics of the rate development. Last year, Kaiser did lose a significant amount of members within their Kaiser plans, and that has a downstream impact on these employee premiums as well. We're really hoping that these stabilize into the next plan year and that there is not another switch in an increase in employee premiums for Kaiser going into 2026, and we hope that these remain somewhat stable. For UMP Classic, I do want to note that this UMP Classic is the benchmark plan. So this is what the employer medical contribution is based off of. So when the employer medical contribution increases at a greater rate than another plan's bid rate, the employer picks up a bigger share of the total rate. So that's also impacting some of the Kaiser employee premiums now. The employer is picking up a bigger share of that lower bid rate. You'll notice that UMP Classic does have an increase of $9. I thought it was important to note, though, that the proposed premium for 2025 of $133 is actually still less than it was in 2023, though. In 2023, that $133 was actually $135. As of last year, we had a change in the methodology for how we calculate the employer's contribution, which puts some downward pressure on that UMP Classic employee premium. And so for 2025, we're still actually below what we were in 2023. So I thought that was something interesting when I was looking at the year-over-year numbers.
Yeah, Tanya, I think that is, well, I'm really glad that you brought that up because as you had highlighted earlier, over half of the population is UMP Classic. It is kind of a plan that has kind of been a bellwether. It's why it's the benchmark plan for the employer medical contribution methodology. And so a lot of people pay, understandably, a significant amount of pressure, attention on that particular plan. And so, you know, if you look at a 3-year look of 2023, 2024, 2025, that is really stable. It's understandable people will focus on the specific change and what is taken out of their paychecks from 2024 to 2025. But I do think it's important to keep in context that in a 3-year look, it is pretty smooth, very similar. And in fact, still, as you said, the current year and next year are lower than 2023. You know, by definition, because it's the benchmark plan and the state picks up 85%, anytime there is an increase, there will, to the cost of that plan, there will be a premium increase on UMP Classic. The state, by definition, is picking up 85% of the increase, so there will be an incremental increase of 15% in that plan. Kind of structurally, that is how the system is set up.
So that's UMP Classic. You'll notice CDHP Plus and Select also have some larger increases than typical, but math, when premiums are smaller, sometimes the percentage is a little bit higher than some of the larger numbers. CDHP and is been around a while. It is a lower price point plan, and as members continue to think, you know, financially when they enroll in plans and look at some of those lower price point plans, that plan's baseline experience, meaning what we use to create the rates, has increased at a greater rate than we've seen historically. So there are more members switching into this, and the base experience for CDHP is slowly increasing. Select is a newer plan. We've only had the plan around a few years, so this plan is maturing. Historically, we used UMP Classic trends to, you know, establish these rates. But now these plans are this plan's standing on its own, and we are using the actual experience of this plan to rate it. So that's driving some of that increase. And for the plus plan, the UMP plus plans are a narrow network plan. Beth and Dave just walked through some of that. And when there's a narrow network, impacts on provider rates can have a larger impact because of the narrow network on the plan bid rate than maybe Classic, which has an open PPO and has all of the provider increases kind of buried in that rate.
Tanya, I just feel like there's questions. I'm going to try and plain talk that one a little bit more.
Yeah.
So the way to think of it is, we're going to tie a couple of concepts together that people are aware. We've been seeing provider. We all know that provider and network negotiations are constantly going on. We've been seeing even more disruption, potential network termination disruption letters month over month in the last most of this year actually. What Tanya's describing is those individual rate negotiations. When you're looking at UMP Classic, you're spreading out any rate increases that are happening in those negotiations across the entire PPO network. Every provider, it's a larger pool of providers, if you will, with those rates. But you have to also then, for UMP Plus, look at just the providers that are in the narrower network. So whereas if there was a higher increase for one of the systems that was in UMP Plus, it might be smoothed out in the averaging process for the entire Classic pool, but you see it concentrated when we're focused on just the rates for that network within that plan. It is also important to note that, this is the first time that UMP Plus's employee premium will be higher than UMP Classic. Up until this point, it has been lower. And a key piece to think about is many members who have been in UMP Plus have been able to enjoy both a lower premium and enhanced benefits. That's kind of no longer the case. Those enhanced benefits being a lower deductible and various primary care visits that don't have a cost sharing. There is a cost share in Classic, and there is a slightly higher. The deductible is $125 less than UMP Plus. So now, as individuals look at this plan, they won't be able to enjoy both an enhanced benefit and that reduced premium relative to Classic. They can still sign up for that plan and have those reduced or enhanced benefits. They just will need to kind of balance that in the equation going forward.
On the next slide, we just take it one step further and we roll each of those single subscriber premiums we were looking at just now through the various tier ratios. So those follow the same 1.7 or 2 to 1.75 and holy cow, 1, 2, 175 and 275. You can refer back a few slides.
Is it, sorry to interrupt.
Yeah.
Is it possible to get the breakdown of the year-over-year change of all the tiers?
Yes, but it will math very similar.
Right.
Yeah.
Yeah. Just all the tiers.
Yeah, I can do that. Right, so that's it on the employee premiums for medical. The next slide is our non-Medicare retiree premiums. Yeah, Harry?
Before we go into that.
Yeah.
Really 3 questions. I'd like to know if you have it available. What was the UMP Plus rate for 2023? They made the point of how in the UMP, this year was actually lower than 2023, I think. So I'm kind of curious, was that?
Yeah, that was for UMP Classic that we talked about. It was lower. So for the UMP Plus plan, I have them all right here. 2023 was actually $97. Then it went to 109 and then the 158.
What is the HSA these days for the CDHP?
It's $700 for the single subscriber and $14 for the family. And there are some pennies after that. I just
On all of the various offerings.
So single subscriber gets $700 regardless of if you're Kaiser Northwest, Kaiser Washington, or UMP CDHP. And then all the remaining tiers, it's $1,400 clear contribution.
Right. Okay. And so the UMP rate includes prescription drugs. So I'm curious with this increase, so how much of that is impacted by prescription drugs? I mean, has it been, because we hear about the new drugs that are coming on, we can go through that with the retirees quite a bit. So there's certainly gonna be some, so I'm wondering how much of this is tied to medical and how much is tied to prescription.
Yeah, I can bring back an exact number, but it's far different than it is on the UMP Classic Medicare side. Because on the Medicare side for UMP, remember that on the medical side, UMP picks up secondary to Medicare, but on pharmacy, it's primary. So the percentage of the total bid rate on Medicare attributable to pharmacy costs is a lot higher. On the employee side, it's closer, I think, to 80% medical, 20% pharmacy, but I will bring you back the exact
Right,
number.
but that 20% is increasing quicker than the 80%. That's really what I'm kind of.
I can bring back some numbers from the
Thanks.
2 years rate development.
So much. Couple of questions. You did mention 2023, which was probably during the network. So it feels this way, I would suggest that trend analysis is always helpful. Things show that it's a tier fluctuation. It's always really weird because there are different things happening within a year.
Yes.
But certainly say a 5-year trend. If it's trying to create more.
We have it.
But if you can present that to us, certainly, obviously there were some changes attributed to the COVID and the staff shortages that we saw post-COVID and trying to make up for that for Kaiser. But if I think if our board members can see a longer analysis over like a 5-year plan.
We have it.
And to just see, okay, what, like when you and Dave mentioned, it's things smoothing out, it's easier for us to see that over that period of time rather than just a single year fluctuation. And again, if there's more work.
It's not more work, it already exists.
Okay.
I can pull it together for the next meeting as follow-up.
That trend.
Are you interested in the employee experience, so the employee premium or the total bid rate? Because it does get a
lot
little,
of information and it gets nuanced. I'm thinking more about the employee premium.
okay, yep.
And to see what's happening, and then you can probably give us the details to why it's not as smooth, why it has fluctuated so sharply.
I can do that.
And I think Tanya would like us to overlay what the employer contribution is on that same type of analysis.
Yeah, I can do that. Yeah.
I know it's shifted from the state index rate to the EMC model, but I think it's important to also highlight the state's contribution to covering as well.
I think, I'm thinking out loud, but there's a slide we have historically done on the Medicare side, which would show of the total rate, the employer and the employee's portion, and we can pull something together like that.
Yeah, the reason that I think it's important to include the state contribution piece is we often have to highlight to people that the state does pick up 85% of the historically it's been 85% for a variety of recent years, but maintaining an 85% commitment comes at increased expense from the state. So continuing that commitment is often tens of millions of dollars more year over year. And so keeping status quo is an actual investment still. It's a hard concept for people to kind of wrap their heads around, but it's also a reason I think it's going to be important just to overlay that state role in the employer contribution for benefits. We'll go to non-Medicare.
All right, non-Medicare. So our non-Medicare retirees are those retirees who are not yet eligible to enroll in the Medicare plans. These employees or these retirees enroll in the same plans as employees, but they pay the full bid rate. So these retirees pay the bid rate plus a small administrative fee. So you'll see on here a comparison of 24 to 25. Then the change in year over year dollars as well as percentages. And you're going to see the same or a very similar theme with decreases for Kaiser and some increases for UMP. Because there is no employer medical contribution added to these rates, there is no direct subsidy. The retiree will pay the full bid rate increase here. However, we do say that these retirees benefit implicitly because they are getting to be rated with younger employees. Whereas if they were to go out and purchase their own policy individually, they would be rated at their, age. So these these retirees benefit implicitly by getting to pay the employee rates, which would bring down what otherwise would be a larger premium for them.
And I think this is a great, actually, slide to emphasize the point that I was just making about the employer contribution. So you see on UMP Classic that for the non-Medicare retired year over year, it's $66 a month. The math rounding doesn't work out exactly perfectly, but it's really close. That is the incremental increase on the plan, and 85% of that in next year is being picked up by the state through the EMC methodology, and the remaining 15% is what shows up on Tanya's prior employee slides as the $9 increase that an employee's experience. But right there, that is the state incremental investment is 85% of $66 for 125, 130, 135,000. And the dependents when multiplied by the tier ratio. So that right there shows the investment year over year, and an illustrative example of that by the state.
I just wanted to thank you for showing this because we hear from non-Medicare retirees a lot about this issue. Having it mapped out helps me. Thank you.
And then next slide is the non-Medicare retiree premiums by tier. The same tier ratios apply here. What is not included in either slide deck today, before we move on to other benefits, is split account rates. That is where there might be a retiree and a spouse, one who might be Medicare eligible and one who might not. The combo does not exist yet, and we do not create those full sets of rates until the board adopts both the non-Medicare and the Medicare rates. High level, you can just add them together. They don't get charged twice for administrative costs, but it's very close to being able to add them together. But if you have any specific questions on any of those combos, we can help provide those. We just do not merge everything together because it's quite a process until after the board adopts the rates.
And it's, I won't say it's, I'm afraid to say the word simple because it's never simple, but it's a simple mapping math exercise from the numbers that the board authorizes, which is why we don't bring you a separate resolution for split account rates. It just immediately flows from the other two numbers.
What proportion of the population do we have that fall in that category of that split account?
Unclear if Ellen falling like that.
I don't know the proportion.
Yeah.
Is it like a negligible? So then just as a general, a negligible amount, or is it substantive?
I'd have to research that. I'm sorry, I'll bring it back for the next meeting.
I guess I think I can safely say that I wouldn't qualify it as negligible. We spend a lot of administrative work to make sure that we can administer those specific accounts. And so it you know, even if it's a small number, it is a significant amount of work. An entirely different rate sheet. I mean, it doesn't matter if it's 10 people or 100 people. Finance has to create a rate sheet that's specific for this scenario. We have to go through communication exercises and help people understand which chart they're supposed to be looking at. We spend a lot of time answering questions about the math. It's essentially ×2 minus $5, but not exactly, but helping people understand why it's that way. There is a lot of manual work that goes into the split account scenario that even if the number is a small number, the work is in no way negligible.
No, and there's logic between, you know, United Healthcare, for example, doesn't have a non-Medicare plan. So the Medicare retiree who's maybe in United Healthcare has a spouse that might be in another plan, which is UMP. But there's a lot of logic that goes. So we spend the next couple months after the board authorizes premiums developing those full rate books and communication materials.
But we will put on the follow-up list to help you understand a percentage of the population that's a split account.
So we're going to move on to other benefits. Next slide, please. So this is our life and accidental death and dismemberment and long-term disability. I just noticed this says 2024 premiums and should say 2025. So we will fix that for next.
The rates are so similar between 24 and 25 that the only difference is the year.
In fact, there is no change in the either the employer or the employee paid rates for 2025. So I will just update the years for the next board meeting.
Tanya, this is where I ask you a question and I answer myself.
Yeah.
Which was, do you know when the last time there was a rate change? You say, Dave, I bet you know the answer, and I do. For both of these benefits, well, I'll start with life insurance and AD&D. When we went out for procurement in 2016 and rebooted the benefit for the first time in 40 years in 2017, we had a multi-year rate guarantee that went through 2024. The end of this year, and we just locked in a new multi-year rate guarantee that extends those rates an additional several years. So we have actually not had a rate change in life insurance since the launch of the quote new contract, which started in 2017, and we will not for several more years at least. I'm afraid to say how many more years because I have so many contracts, so many numbers, but we do have another multi-year rate guarantee that extends the original 8-year rate guarantee that we had on life insurance. So we haven't seen any movement in the premiums that employees have been paying for. We're going to hit at least a decade before there's even the possibility of a rate change in that area. So that's really good kind of stabilization there. And we also, there has been some fluctuating within the LTD. You might remember that a couple of years ago, the board authorized an opt-out benefit instead of an opt-in benefit, and the rates had to be restructured there. So there has been some on the LTD side. But I did want to make sure that everyone was aware that it's been many years since life insurance has changed.
Question?
Yeah.
I guess we're moving on.
No worries.
No discussion about dental? I know it rarely changes, if anything, but past it seems to me we've done resolutions on it nonetheless.
The board doesn't pass resolutions on the employer paid benefits because your authority is about setting employee premiums. I do think there was something at one point where we talked about because retirees pay, but the board's authority is on the employee premiums side of the equation. So that's there aren't resolutions there, but
I'm not sure about that, but I do know that we've seen rates in the past.
Yeah, we'll bring that back next meeting.
I can tell you that there is a rate guarantee for the Delta Care rate, so there would be no change in Delta Care. And that there is a rate guarantee also for the third-party administrator fee of the Uniform Dental Plan through 25. So only the claims portion is going up, and that's going up just slightly. And then there's also a rate guarantee for Willamette. So there's very little change, just a small percentage change on the Uniform Dental Plan because of the claims costs.
And now I remember, Harry, we still have, as we were finishing up the slide, there were a couple of things that we were planning to do vision and dental at the same time, and we're still finalizing something with the vision rates. And so since the board doesn't vote on them because they're employer paid, we were planning to bring it at the last meeting anyway to share it. So you're right, we usually do share it. We were putting them on the same slide and we moved that slide to bring you at the end of the board season, just as information.
And vision, I understand there's no premium to that. I mean, there is premium, but the employees don't pay that, correct?
Correct. Same with dental.
But if you wouldn't mind, if it's not too much trouble for somebody to look back the last couple of years of resolutions, I'm certain at some point, my mind is certain that at some point we were doing some kind of resolution on the dental.
I remember there was one year where Katie mentioned a question about it, but year over year we haven't had dental, but we can go back and figure out what the scenario was that caused you. I do believe you're right. There was at least one year where there was a question that went through a dental piece, but typically it is the same core set, but we'll go back and follow up on that because of the recollection.
I remember Ellen presenting proposals to increase dental coverage.
That's true.
That may be what you're thinking of, but I don't know. That's what I remember. But
Yeah, I think that was the context, Ellie, when we were talking about changes and seeking a decision package on enhancements to the Uniform Dental Plan. There was the conversation that any change that was made would ripple over into the retiree rates and would be 100% paid. And so we were comparing, contrasting what the state might pick up in an employer paid benefit versus what a retiree would pay. And I think that that is the context in which is there a resolution or not a resolution came up, but we'll dig back into that. I do know that year over year, there's not consistently been a dental rate, but I remember that kind of conversation and where that is. So we'll dig up that and make sure that we can describe that in the last board meeting. And then also we were gonna bring a slide that was related to both vision and dental. Since they are both employer paid grades, we were still finalizing some things with vision, but we'll bring that on the 11th as well.
All right, next up is proposed resolutions. So these are for medical. I won't read through each of these, but how these are structured are one resolution per carrier. And by the board authorizing each of these resolution, it authorizes the premiums as well as the benefit design that Beth walked through earlier. So any benefit design changes would be incorporated in these resolutions. So the first one is just an example for Kaiser Northwest. It says the board authorizes the Kaiser Foundation Health Plan of the Northwest employee and non-Medicare retiree premiums. And we would have the same for Kaiser Washington and the Uniform Medical Plan. So I have some follow-up I'll bring with these resolutions at the next board meeting. And then I'll pause for any additional questions.
Thank you, Tanya. If we want to take a brief break, to have a natural shift between non-Medicare and Medicare.
Let's go ahead and take a 10-minute break. We'll be back at 10:45. ran over a little bit. That's okay. We're ahead, and I want to make sure that people who are planning to be here for Medicare were closer on timing. I would think it would be better. It all worked out.
Can I ask how the donut supply is doing? I'm sorry, I'm missing it.
The donut supply is very healthy.
Great. I'm sorry I'm missing it. That's one of my favorite things about our meetings.
Better about this time, John.
We supply donut holes because they don't exist in Medicare anymore. Molly, you're gonna address that later? Well, yeah, see, insurance joke. It's a slight late Father's Day dad joke. It was crazy as we love it. That was.
It's terrible. It's a lawyer. Only a lawyer.
I have a good lawyer joke for you later, Elliot. When you're done the meeting and not recording.
We can't be heard.
All right, next up, we have Stella in, Policy and Rules Coordinator, and the IRB Division is bringing back 2 resolutions for voting today regarding coverage for International UMP Classic Medicare with Part D members. My materials are behind tab number 9. And after Stella reviews each of the resolutions, we're going to ask for a motion to adopt. We'll invite the public to comment on the resolution, and we're going to ask for the board to discuss. It is tab 8. Thank you. I saw 9 slides and I read. Tab 8. Thank you, Elliot. And we're going to have a discussion until we're prepared to vote. Stella, you're up.
Good morning, Chairman McDermott, members of the board. My name is Stella, First Division Policy and Rules Coordinator. Next slide, please. This slide and the next slide are included in the presentation, so the board will have them available for the policies we will discuss. Slide 4, please. Here are the policy resolutions for action. The 2 deferral policies for PEB retiree insurance coverage address Medicare subscribers who permanently live in a location outside of the United States. Next slide, please. Resolution PEB 2024-26 allows retirees and survivors who are enrolled in Medicare to defer enrollment in PEB retiree insurance coverage when they permanently live in a location outside of the United States. We have one minor deletion on the resolution, and we received no feedback on this resolution. Are there any questions from the board?
So as a reminder, there are 2 resolutions here. This first one is kind of the permanent future state, if you will, related to the deferral rule. And the second one that Stella is bringing back is about the transition of people who are currently in coverage residing outside of the United States. So this is kind of like think of this as the permanent rule policy, and the next one is about transitioning and addressing the roughly 20 people who currently are in this scenario, but future people when they move and permanently live outside the U.S. These would be the rules going forward. Elliot?
I have kind of an obvious question. If you're permanently living outside of the U.S., why would you defer? You're never going to come back and you're never eligible. Am I missing something here?
So Elliot, the way I think about this is I think about a question that used to come up in the sub board. We had a board member that would ask me, when is final, Dave? And final is final while it's final, and then things change and circumstances change. And so somebody may think that they are going to forevermore live outside of the United States, but life circumstances change, things happen, and what they intended or what they thought was going to be their path in life, suddenly they are moving back to the United States, although they may have thought that they were going to live forevermore outside of the United States. So permanent doesn't mean forever etched in stone until the end of time. It means their kind of manifested intent for where they are right now in their life journey.
Not that, but I just wanted to make sure that I was right. Okay.
You were right, Elliot. For the record, you were right.
Michaela had her hand up for a minute, then she put it down.
Michaela, do you have a question?
No, I got it. Thank you.
Okay, thank you. Good. All right, we're gonna go ahead and vote on Resolution 24-26, PEB retiree insurance coverage deferral permanently live in a location outside the United States. Resolved that effective January 1st, 2025, retirees and survivors who are enrolled in Medicare may defer enrollment in PEB retiree insurance coverage when they permanently live in a location outside of the United States. Evidence of continuous enrollment in a qualified coverage is waived while a retiree or survivor enrolled in Medicare lives outside the United States. A retiree or survivor enrolled in Medicare who defers enrollment while permanently living outside the United States will have the opportunity to enroll in PEB health plan when they return to the United States by submitting the required forms and proof of enrollment in Medicare's Part A and B within the healthcare HCA's required enrollment timeframe. Is there a motion to adopt?
So move.
Is there a second?
Second.
Are there any comments from the public? Seeing none, are there any comments from the board? All right, this is going to be a roll call vote, starting with Elliot.
Aye.
Harry.
Aye.
Kurt.
Aye.
Sharon.
Aye.
Michaela.
Aye.
Tom.
Yes.
And Lou. Yes, I'll go with Tom. Resolution 24-26 passes. Thank you all.
Slide, please.
There we go.
The second resolution, at 2024-27, addresses all Medicare enrollees who are enrolled in UMP Classic Medicare with eligible drug coverage who permanently live in a location outside of the United States and did not make an election during this annual open enrollment. We received one stakeholder feedback regarding how this would apply to rules. Because the implementation of this policy will occur before the PEB rules become effective January 1st, 2025, we will implement this resolution to our administrative policy instead that describes when a subscriber is exempt from the retiree deferral form requirement. Are there any questions from the board?
All right. We're going to have resolution PEB 24-27, automatic deferral, PEB retiree insurance coverage for Medicare subscribers who permanently live in a location outside of the United States. Resolved to all Medicare enrollees who are enrolled in UMP Classic Medicare with credible drug coverage as of December 31st, 2024, and permanently live outside the United States where the subscribers did not make an election during the PEB annual open enrollment period held in 2024 will automatically be deferred from PEB retiree insurance coverage with an effective date of January 1st, 2025. These subscribers will be exempt from the deferral form requirement. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Are there any comments from the public? Seeing none, any additional comments from the board? This will be a roll call vote starting with Elliot.
Aye.
Harry.
Aye.
Kurt.
Aye.
Sharon.
Aye.
Michaela.
Aye.
Tom.
Yes.
And Lou, yes. Resolution 2024-27 passes. Stella, next steps.
So the next steps will be guidance to employee agencies on these resolutions and will prepare communications for our members and incorporate resolutions into our program rules.
Awesome.
Thank you very much.
Any additional questions for Stella? Thank you, Stella.
Thank you.
Appreciate it. Are we going to just go into our next?
I recommend we go with Ellen, then we'll do a quick break to pass out lunch, have lunch while Ellen.
Perfect. Ellen Wolfhagen, retiree benefits manager in the Urban Development. She's going to join us today to give a Medicare update, similar to Beth's presentation earlier today. Ellen's update helped inform benefit changes, which ultimately inform next year's member monthly premiums. Materials behind tab number 9. Ellen, welcome.
Thank you, Chair McDermott, members of the board. Pleasure to be back here with you again. Next slide, please. So I'm going to be talking about benefits changes in the United Healthcare Kaiser Foundation, Northwest and Kaiser Washington Medicare plans. And then we'll have a discussion that relates just to Kaiser Permanente. So starting with the benefit changes, next slide, please. For United Healthcare, so United Healthcare, as a reminder, uses its own network, which is known as United Hearing, for both PEB Balance and PEB Complete. There is no coverage for out-of-network providers. The most expensive hearing aid in-network is $1,900 per ear, and the benefit it would increase from the current $2,500 combined for 2 ears to $3,000 per ear every 36 months. So emphasizing ears versus years.
Ellen, before we move on for this slide, because I said we'd be talking about hearing aids later this afternoon. We spent a lot of time talking about hearing aids in recent years, and I just want to draw attention to this particular change because we have received a fair amount of correspondence from retirees throughout 2024. You might remember that the legislature in 2023 passed a bill that addressed hearing aids in the commercial market in the state of Washington related to the dollar amount that would be covered. And I believe that the legislation may also have included kind of the frequency, but multi-month, I'm going to keep saying month because year and year are so similar to each other. And that bill got implemented in the PEB program in the employee plans because the legislation was specific about the employee plans. The legislation didn't address retirees. And in fact, it probably couldn't because the state can override or mandate changes within CMS's regulatory space on Medicare plans. So the legislation actually couldn't have mandated a change in Medicare plans that are offered in the state. But consequently, we had many retirees who understandably heard about this increased benefit, the $3,000 that was happening. It's like, why isn't it happening in the retiree space? So it's a discretionary change. That legislation, long sessions happen, they're happening going into late April. We were working on rate development. We were able to, you might remember this, we addressed with the carriers. We used to have most of the benefits. The frequency was every 5 years, every 60 months. And so there were 2 pieces that could be aligned with the legislation: the frequency, the number of months, and the amount. And so last year there was a shift. We were able to build this into the rates because it was relatively small incremental increase in the rates to move to that 36 months from 50 months. And we said we would come back and talk with the carriers about a potential change in the amount to align with the legislation because so many people are wondering why people are being treated differently. It wasn't a discriminatory act or age discrimination. It was the state can't mandate it. It was something we had to do through the contractual process. And so we were coming back to the board and going back to the carriers to talk about that. And now you're seeing the fruits of that labor work manifesting for all of the carriers working on some amount of change to align. I believe all of them are moving to align to the $3,000 so that in the PEB portfolio, in our retiree and employee space, the benefit amount would be essentially the same across the portfolio. And then hopefully that will address and we won't see those questions coming up that we need to help people understand. So that's kind of the journey as it relates to the $3,000. Ellen, Ellen, Tom, you have a question.
I have a question. So I just want to make sure, Ellen, that I'm understanding this. If for some particular reason I chose to have the most expensive hearing aid, $1,900 per ear, were I to choose that, I needed it for both ears, then I would pretty much have to spend $800 out of pocket. Is that correct if we were to adopt this? I just want to make sure I'm understanding it.
Yes, that is correct. So that the member would pay any amount above the, I'm sorry, that's not correct because $3,000 per ear would be $6,000. So $3,000 is more than $1,900.
Oh yeah, okay. I missed that. Okay, thank you.
But you caught me as well. So good question, Tom. Okay, next slide, please. So as Dave so eloquently spelled out, Kaiser Northwest is also moving to $3,000 per year every 36 months. So again, increasing to match, and also increasing the vision part where you know that in the employee arena, the vision benefit is moving to $200 And so Kaiser Northwest is moving to $200 every 24 months. And that's a vision hardware benefit. Next slide.
Oh, John has his hand
Oh, John.
You're muted.
I apologize, I wasn't muted. I was muted. In order to benefit from the hearing aid option, do you need to be in the into one of the medical programs, or is this an optional program?
No, these are benefits under the medical plans. So you would have to be a member of the medical plan to take advantage of it.
So you couldn't, for instance, defer entry into the medical plan and have this benefit. You'd have to be a member of the medical plan and receiving your health care. Thank you.
Yeah. This is not a standalone benefit.
And that's important to emphasize, especially on vision. Ellen's comments about vision she's speaking of the Medicare, with the Medicare hat right now. Vision will continue to be embedded in the Medicare medical plans. Just keep that in mind while we're moving to standalone vision on the employee and non-Medicare side. In the Medicare space, vision hardware will continue to be embedded. And you're seeing Kaiser Northwest, and Ellen will talk about the dynamics of vision and the other carriers, but you're seeing that increase so that the experience is similar, whether from a benefit level, whether you're Medicare or non-Medicare. But just remember, vision is embedded in Medicare medical going forward, but it's standalone.
And
it's not Medicare requires.
So I have one more question.
Sure.
So does that mean that, well, I want to make sure, non-Medicare retirees in this particular case would be in the same pool as employees would, not in the Medicare retiree, but in the non-Medicare retirees would be in the same as active employees?
That's correct. So non-Medicare retirees would be able to take advantage of standalone vision plans.
Okay, thank you.
Okay, next slide, please. So for Kaiser Washington, so this is different from Kaiser Northwest. Kaiser Washington is increasing the hearing aid benefit again to match the portfolio across $3,000 every 36 months. And it's worthy to note that the vision hardware benefit under the Kaiser Washington Medicare Advantage plan is currently $300 vision hardware allowance every 24 months. So there's no increase there because they've already been at that level.
They're also not decreasing.
They're also not decreasing. Before we move on, are there any questions about any of the benefit changes that I covered? Hearing none, let's move on. So now we're going to talk about some specific changes in Kaiser Permanente. So this map shows the service areas for Kaiser Washington Medicare. Currently, so 2024, it's all of the shaded areas in both colors. In 2025, they're moving to a slightly smaller service area. So it'll only be the areas that are in dark blue. This is a service area change because the dark blue areas are places where Kaiser Permanente has impaneled providers. That means they are directly under Kaiser Permanente. Next slide. So again, the 2025 plan offering focuses on the impaneled providers. At least 99% of the members in the light blue counties on the prior slide were not seen by a Kaiser Permanente medical group provider. That is, they were not seen by an impaneled provider. There were a total of 150 providers in those counties who had claims in the past year with Kaiser Medicare members. Only 3 of those providers overall have not submitted claims to any other PEB Medicare plan. So based on the 2023 claims, most of the providers have already submitted claims to the other Medicare plans offered, and the percentages are here. But again, a caveat that the percentages are based on claims submitted. So it is possible that the numbers could be higher. We just haven't seen a claim yet from one of the providers. But generally speaking, there's very good coverage and overlap between the various plans. Next slide, please.
Before we move on from this piece, what I want to really highlight is the way our annual procurement process works. And I've kind of described this in a lot of different ways over the years. Is a package is brought to us at Kaiser or any carrier, but I'm just going to say Kaiser because that's what I'm talking about, brings a package that is, here are the terms of that package. Here are the rates, here's the service area, here's the benefit design. And the package that we are looking at this year is really just kind of, again, focusing on those empaneled Kaiser providers, which is, there will be members that are in those light blue counties on slide number 8 that will need to transition to a different plan in the portfolio. And what Ellen has highlighted is most of them are going to be able to move into another plan. They may have 1 option, 2 options, or 3 options. It will just depend on the individual provider, but we wanted to kind of reassure you, reassure the members of the public, reassure retirees who are in those plans. There will be targeted outreach to talk with them and explain to them what their options are. But on the whole, people will have other options within the portfolio that exists today. And when you look at the numbers at the bottom of slide 9, it's not that there's 10% of providers that don't have any engagement. It's just those percentages aren't deduplicated. So, there's some of the providers are submitting to all 3 of them, some of them are submitting just to 1. You can just see there's 90% UMP, but that doesn't mean the other 10% aren't either with United or with Primera. So as Ellen was highlighting, 147 of them, we see claims somewhere in the system. The other 3, they just didn't have claims in 2023. That doesn't mean that they aren't engaging, but there will be very targeted outreach to help people understand what their choices are in we call it the customized letter, customized packet that goes out to retirees in early to mid-October every year. It will help explain to people, you're in this plan today, the future plan options that you have tomorrow are X, Y, and Z, and it will help people be able to navigate what those choices are. Elliot first and then Chair.
I also hope that it'll be online because I have found over the years your online communication is really excelling and is a great help to members.
Yeah, there will absolutely be the kind of general description. I think one thing people really appreciate is that customized letter that helps them weed out the parts that don't apply to them. So it's a both and, it's not an either or. And then Sharon, you have a question.
Okay, so this is not perhaps under the purview of the CA, but my understanding of the panel providers are those that have substantial or established relationships with patients and providers. Is that correct? They have an ongoing established relationship.
So
that's what that is.
I believe that the term empanelment has to do with the employer-employee relationship between Kaiser and the providers, right? Not the relationship between the provider and the patient. So these patients, at least 99% of the current Kaiser Medicare patients who live in these areas, they're seeing providers that are outside of the Kaiser employment arena, if you will, right? So they're seeing other providers outside. So for example, Dr. Jones. Dr. Jones accepts Medicare. They are seeing the Kaiser patient through a what's the word? A voluntary agreement with Kaiser, right? We'll see your patient on behalf of Kaiser, but we are not employed by Kaiser, right? And that's how that's working. Tomorrow, or actually January 1, 2025, that same patient can see that same provider under a different plan.
Well, thank you for that. And the only reason why I asked that question is that it felt like patients in the light blue area, there's a sense of instability in terms of that relationship. And if that's the case, then I'm concerned about folks in that area because of that level of instability that makes them vulnerable for what has happened here. I know it's not within the purview of what HC does, but that is something that just caught my eye. Sorry.
I think it's important to emphasize it's this impaneling piece that we're describing is really about like network contracting. It's not a perfect analogy, but the way I think of it is the light blue counties are kind of like the expanded PPO network. It's not a great analogy, but like they have their employee impaneled providers and their brick and mortar facilities, and then they have these extra provider contracts that kind of wrap around their core network. And these providers, as Ellen said, come January, these members would still be able to see those same providers. It's just the plan that's paying their claims and that they're paying premiums for isn't named Kaiser. It's named United Healthcare, it's named Primera, it's named Uniform Medical Plan, whatever they choose. So it's this disconnect between they are in a Kaiser plan today, but the provider they're seeing isn't a Kaiser provider. They're in network via an agreement, and come January 2021, or sorry, 2025, not 2021, I haven't said much, they can still see that exact same provider. So it's not instability in the provider member relationship. It's really about who's the payer for this plan. And we're just saying that going forward, Kaiser's plans are focused on the impanel providers in the Medicare space, and these members then will just need to pick a different payer. They don't have to pick a new provider.
To follow up on what Sharon just said, I have heard from members of this group, the Kaiser group, and they do feel, that's why I'm glad you'll be communicating, they do feel that their outlook is unstable. And although you have articulated the reality of this very well, it just underscores the importance of them hearing from you, because Sharon did nail it. I can't answer it, but you guys can.
Good to know that the messaging Ellen and I were just doing makes sense here, and then we just need to push it out.
Now we're going to transition to a discussion of transitioning from Kaiser and Medicare Advantage, which we call MA, to Medicare Advantage, including Part D prescription drug coverage. So from MA to MAPD. So just like the United plans are called MAPD plans, the Kaiser plans for both Kaiser Northwest and Kaiser Washington, they're what are currently Medicare Advantage plans in 2025 would become Medicare Advantage Part D prescription drug coverage plans. So the reasons for the change, these are very similar to the reasons that we discussed, the logic behind the switch in UMP to Part D coverage, right? There are cost savings through lower cost shares, an added benefit of reduced copays in some cases and maximum out-of-pocket limit that's set by the plans. Inflation Reduction Act enhancements. Now remember, Inflation Reduction Act applies to all Part D plans, whether they are individual employer group waiver plans like our plans, or commercial, or again, under our portfolio, which is employer group waivers. Those protections under IRA include premium increase protection, maximum out-of-pocket calculation that I'll go into in more detail in a bit, and the drug price negotiations that are currently taking place that affect drugs under the Part D market, if you will, because again, it's all Part D plans, whether it's commercial or not. And these benefits accrue only to Part D plans. So there's a real payoff for members to have that kind of protection. It will be a CMS approved Medicare formulary. It is substantially similar to the formulary that currently exists for both the Kaiser plans. And there, just like in UMP, there is absolutely no change to the medical coverage. So as it currently exists, that's what it would be going forward. Next slide. So again, very similar to the discussion that Luke had, our pharmacist, on the UMP and the Part D. There are protected classes. The formulary has to cover all of these kinds of drugs. These protections are even more extensive than exist currently in the non-Part D space. We often get asked about cancer drugs, for example. All cancer drugs are covered under Medicare Part D. There's no exclusion of drugs just because it's Part D. And there is a benefit. Some medications currently are on Tier 4 in the Kaiser structure, and that will change to a lower cost share in the new structure. Again, as the plans get approved by CMS, there is some juggling, if you will, among the tiers, right? Different tiers have different drugs included in them, and so there may be some transition. In this case, it's a very positive transition because some drugs will move from a higher cost share to a lower cost share. Next slide, please. So again, if a drug becomes non-covered, all of these Part D benefits are similar, again, to what would happen under UMP. If a drug becomes non-covered, members are grandfathered for the remainder of the year, so there's a minimized impact during the year. Prior authorization and step therapy requirements are generally less restrictive under Part D, so this is a great benefit for both UMP and for these plans. And there's a minimal change to the exception process. So again, there are some switches between tiers on things, but it is a less extensive process. And then just a reminder, under Part D, the appeals of prior authorizations or step therapy requirements must be resolved more quickly than under the current structure. Under CMS for all Part D plans, a normal or regular appeal must be resolved, pharmacy appeal must be resolved within 72 hours and an urgent appeal within 24 hours. Next slide. So similar to the discussion we had with UMP, most generic and brand medication cost shares would not change. So there wouldn't be an increase. Some drugs will be less expensive under Part D. And members who have high cost specialty drugs. So again, specialty drugs are usually not things that you stay on for a very, very long time or that you have every month, but they're specialty medications. They may have a higher cost. That's usually less than 1% of all the prescriptions written for an entire year. So it's a very limited increase. Members will pay a higher cost share, and we'll go over that in a minute. But most members will reach the true out-of-pocket, which is known as the truth, during the plan year. And again, I'm going to go through this in a little more detail coming up.
Ellen, before you go on to this, I think this is just a really important point to compare and contrast, because there's a lot of similarity in the conversation that we had with the board throughout the first part of the board season. And you might remember in the UMP context, we talked about the very low number of prescriptions that would have a higher out-of-pocket cost whenever you fill that prescription. But it was important to weigh that against what were the anticipated significant drops in premium that would happen over the course of the year, and that we didn't anticipate. I believe it was for the 2 to 3% of members who had those prescriptions that there would be very many people who, at the end of the year, from a net financial standpoint of looking at premium and those out-of-pocket costs, ended up behind. And that number, that 2 to 3% of members, Ellen will go into this, it's a little bit larger in the Kaiser area, but at the same time, we have to remember, and Ellen will emphasize this, the troop and how people will can't underestimate the value of the troop, which is the true out-of-pocket max, which is the new calculation. So I'm going to make sure that Ellen really emphasizes how that troop works and how that is really the backstop protective measure for any of these members in either plan who are paying more for specialty drugs. And the reason I have to emphasize that is the premium differential that comes from this shift in the Kaiser is not as great as it is in UMP because of they're coming from a Medicare Advantage plan to a Medicare Part D. It's not an apples to apples UMP to Part D as Kaiser is to Part D. So the premium depression, they were able to leverage some of the other subsidies in a way that UMP couldn't before. So there's a more profound premium difference in UMP than there is in Kaiser. But this troop is really a backstop in both instances that helps ensure that most people at the end of the day shouldn't end up, from a net financial perspective over the course of the year, end up paying substantially more.
Next slide, please. Again, virtually all the drugs that are currently covered will be covered under the Part D formulary, and as currently exists with the United Healthcare plans for what will happen in UMP Part D. The bonus drug list will include items that aren't necessarily covered today. So the bonus drug list will include things like vitamins, over-the-counter, nicotine replacement, and other standard over-the-counter products.
So, excuse me, I have a question.
Yes, Tom.
Is bonus drug list will include vitamins, over-the-counter nicotine replacement, and other products. Is that true also for what we adopted for Uniform Medical?
So I'm not sure about the vitamins. I'd have to research that, but it is true of over-the-counter products, certainly the nicotine replacement, and there are other products under the UMP Part D formulary.
And then my next question is, so for example, if I'm understanding this correctly, if I take like a vitamin B complex and maybe vitamin C, I would now be able to submit that to my drugstore and receive reimbursement for it, or I wouldn't even be charged for it?
So it depends on the plan, and it depends on when you say your drugstore, Kaiser has its own limited pharmacies. But for example, it's not usually a daily vitamin, but it's things like if a doctor prescribes, for example, vitamin D as a supplement that's needed, or calcium as a supplement that's needed, those things are covered and get submitted as any other generic drug on the Part D plan.
Okay, thank you.
And I am absolutely certain that the same would apply for UMP in terms of the doctor prescribed vitamins. If it's a supplement like a vitamin D supplement or B12 or something, that would be covered. Next slide, please. More, thank you. So this slide illustrates some of the details of the cost share structure. And one of the things I want to point out is that currently Kaiser does not have a limit on the pharmacy drug spend. So if a member was on a very expensive drug, a specialty drug, if it was the most expensive and so their cost share was $200, if they had that drug every month, and if they had more than one drug every month, they could very easily spend over $2,000 in the year, right? So the fact that the Part D has a built-in cap at $2,000 already represents a savings. So to Dave's earlier point, the overall net financial picture is better.
Oh, wait, there's more. How does troop work?
Well, thank you for asking, Dave. So this is a little bit in the weeds. So troop is based on the members' out-of-pocket cost share. However, in 2025, it's calculated against the standard Part D copay. So the standard Part D copay is what's available on the commercial market on individual plans. Those plans have higher cost shares than anything that we have under the employer group waiver plan. One of the advantages of an employer group waiver plan is that we can negotiate for lower copays. So our members will never pay as much as an individual member on a commercial Part D plan, whatever their set copay is. It will always be higher. But the way that the troop is calculated, it's based on that higher copay. So for example, if under the plan, our copay is $20, but the standard copay would be $50, in calculating the troop, what the member has to pay, they are credited with the $50 limit. So they will reach that $2,000 much sooner because they're not actually paying out $50, they're only paying out $20. But the calculation's going to count $50. So I know that's a lot of numbers, but I think everybody here got it.
I think the ironic part is it's called a true out-of-pocket maximum, but it doesn't represent what the person truly paid. It represents the credits that they received as if they were in the individual market.
Right. Right. It's true for the individual. How do they know that? So the plans keep track of how much they are paying and what the calculation is and the plans for.
But the individual, it'll be blind to them basically. Yeah.
It depends on the savviness of the individual and the calculations.
The good thing is it's just good news. You've already reached your maximum. You've reached your cap. And you're right. We'll probably need to work on some sort of helping people understand, well, how did I reach a $2,000 cap when I only spent $1,000? Some people won't question it. Others will be happy. Some people won't want to ask it because they're afraid that then they'll have to pay another $1,000. But it'll be good news when they hit it because they didn't actually pay $2,000.
And once they reach that troop limit of $2,000, then all of their prescriptions going forward for the rest of that year are $0. The plan pays the full cost.
I would personally, based on my experience with Medicare retirees, I think it would be good for the Kaiser people to let them know this. Does this apply to UMP as well?
So the troop calculation does apply to all Part D plans. It applies to commercial Part D plans. It applies to our employer group waiver plans. Yes.
So just from my experience, thing I hear about more than anything else is the cost of drugs, and that they're not getting all the information that they should from HCA. And being given this good news, I'll be honest with you, when I get my statements, I'm in the middle of something and I really don't focus like you do and understand it like you do. I think the members would really appreciate this news.
Absolutely. And part of our communications will be, especially in the Kaiser realm, that they never had a pharmacy upper limit, right? There was no cap. So regardless of how you calculate the troop, the $2,000 limit is an improvement.
Whereas in UMP, we had a $2,000 cap in UMP Classic today. But our members in UMP Classic Medicare Part D January, will benefit from the troop calculation aspect. They won't. There's always been a cap. Kaiser gets the cap and the troop. UMP gets the troop.
They need to hear that when they don't have information, they get concerned.
Okay. On this slide, whoops, can we go back? On this slide, the next to last or penultimate line, you'll see that the non-preferred brands that under the current plan, members pay 50% of the cost of the drug up to $200. And under the Part D option, it's $100 flat copay. So that means if somebody's drug cost was less than $200, they would actually be paying a little bit more. But for most specialty drugs and non-preferred brands, they're going to reach that limit anyway. So the $100 is better than the $200 limit that they had. Now we can go to the next slide, please. So these are, top drugs by utilization. You're going to see a lot of things here that are very similar to the drugs that we listed when we went through UMP. A lot of statins. The only thing that I'm going to point out here is line 8, the one touch. I believe that this is actually a delivery method, like a pen delivery method. And the reason there's a difference here is because it will be covered under Part B, a medical benefit, and not under Part D. Next slide, please. Elliot?
The one that I'm curious about is 13. You have a small number of members, and yet it's highly utilized. Is there something I don't understand?
I think just because this is Kaiser Northwest, which has a small population. So I don't know overall the entire enrollment, but I'm going to guess under 5,000. So it could be that a small absolute number of members relates to a larger percentage. Remember how math works? That so
got it.
Yeah.
Ellen?
Yes.
Why do they list the atorvastatin 3 times?
I believe that's different dosage limits because it comes out in different ways. So
Okay.
somebody could have it as, I don't know, 20 milligrams. Somebody could have it at 40 milligrams.
You understand, yeah.
I'm not a doctor. I don't play a doctor on TV.
The other piece to highlight is this is a utilization ranking, but it's not that utilization is different than member ranking. Utilization is about prescriptions. And so that's why if you look at these two slides in tandem, 18 and 19, it's not a straight ranking of the member list. But we were doing a member count, but member count isn't the same as annual utilization of a drug because you get multiple prescriptions filled. It's how you count utilization versus lives. So that's another piece. So it's the small number phenomenon in general question with the overall enrollment of Kaiser Northwest. That's only in 2 Southwest Washington counties, but also that difference between member lives and utilization.
And it's also important to note that although it's only 2 counties in Southwest Washington, this is the Medicare population, so people could be in Oregon and also be on this.
Just add a bit more. So you didn't make a clarification between members versus utilization, but the head could say utilization, so it becomes very confusing about what it is we're seeing in the data. So I was just really thinking about how do we capture that utilization piece as opposed to the membership piece.
Yeah, I think when we first started putting this is a similar format to what we did in the UMP slides a couple of months ago. And we were focused on the prescription count. And I think a question came that was like, well, how many member lives is it? I said, oh, so we'll just slap that in there and didn't think about that disconnect between the title. But that's kind of I think the journey of this slide and how this came about. But it really is. So you're right. We can find a way to describe and make sure in the future if we're putting both words and numbers that we can help people understand the difference in terms.
Just one thing, David, before I go. And so which type of ratio would be most beneficial for us to see, utilization piece or just the membership? What is most efficient for us to have a sense of what's
I think we chose utilization because we wanted to answer the question of what is the I can't remember how many drugs, actually, I think this was on one of your subsequent. We were trying to answer the question. I remember in UMP that we were like, 52% of drugs are covered by these 25 on the list. And we were trying to give the board a sense of the majority of drugs that were happening. But then people wanted to know, well, how many members are actually affected by that? And so we run into this phenomenon. It happened with the rate slides a couple of years ago. We used to report, Tanya's slides only reported the dollar change year over year. People said, well, what's the percent? And then we did percent and everyone said, well, what's the dollar? And so then we always use both of them. And so it really has, I think we've had this experience where if we only describe it one way, we always get the question the other way. So we've learned to just describe it both ways. But I think we do need to juxtapose
Yes.
what those definitions are.
We do juxtapose the two though. Very helpful.
So I feel like we would yo-yo like we did on the rate piece and get asked the other one when we didn't do both. Though I think we just need to make sure people understand the difference as we give both numbers.
I think the other factor that we have to include is people get multiple prescriptions, right? So if we're talking about total prescription numbers, if I get a prescription every month for a certain drug, that's really 12 prescriptions, but it's only one member.
Yeah, it's gonna be very hard to get into those kinds of needs, but what you mentioned about the juxtaposing utilization with a membership, I think can be helpful at least as a start.
And then I'll highlight that the reason that everything's green on these slides is we were trying to highlight people don't end up in a worse position tomorrow. I think there on the UMP slides, there was one row that was, I think, gray because it had some instances. We were trying to do the same color coding we did. So you might wonder, why is there so much green on this page? Well, it's to emphasize people don't end up worse. They're the same or better in the future statements.
And in almost all cases, they're the same. However, I'll show line 21, the cost share will actually drop. So however many members take advantage of that level of prescription, they're gonna see a drop.
And similar to the question a few minutes ago, yes, line 21 and 23 are the same drug, must be different prescription strength. And yet somehow we have for lines 14 and 15, the information to list that prescription strength, which reinforces that it is about prescription strength.
Okay, next slide, please. Now we're going to move into Kaiser Washington, and I will try to remember that. So again, Kaiser Washington did not have a pharmacy upper limit, a cap on the pharmacy spend. And so immediately there's a benefit of moving to Part D because there's a $2,000 cap. And I'm not going to go over the entire troop calculation again, but it pertains here as well. Again, there is a drop in non-preferred brands for those that cost at least $200 because the member was paying 50%. So if it costs $200, the member paid 50%, that's $100. Under Part D, it would be $100 flat copay. If their drug was less expensive than that, then there'd be a slight increase. And their specialty drug coverage for Kaiser Washington was by exception only. As was made clear in earlier slides, there are protected classes under Part D, so there's an automatic tier for that drug, and it would be at $250. The footnote notes that all costs are expressed in 30-day fills, and it says does not include mail order. I want to make it clear that mail order is possible and it happens and you could do it. It's just not included on this slide. Next slide. This is a similar representation of the percentage by utilization, so the most commonly prescribed drugs. Again, you may see a number of drugs repeated because of different strengths, and it contains the member count as well. Again, everything is in green because the cost share either is exactly the same or is less. And for Kaiser Washington, it is exactly the same for all of these drugs. Next slide. One more. Thank you. So the previous two slides, so in terms of the utilization overall, Sharon, this is 94% of all the scripts that were written. So, you know, it's not 94% of members. And if needed, we could do, you know, a member determination, but it does represent all the prescriptions that were written last year. And then based on 2023 claims. So again, people's drug needs may change. Medical conditions change. So the need for drugs may either increase or decrease, but based on 2023, there are about 2,500 prescriptions, so actual drugs that need further medical review. So CMS has requirements for certain things, that the diagnostic code has to be a certain kind of diagnostic code. For example, there are some drugs, it might be a topical fungicide, but it gets used for something else, and it has to have a matching diagnostic code. So that's what that extra review is for. And this level of determination, some things are covered under Part D. Remember some things are covered under Part B, like Boyd. Remember, Part B covers injections. It also covers infusions that you get at the doctor's office. So currently, somebody may be paying for that as just a pharmacy claim, but under Part D, it's going to move. It's not going to be under the pharmacy part of the plan. It's going to be under the medical part. And overall, this is about 10% of all the prescriptions that were written where this extra review is required, and Kaiser is engaged in these reviews so that they can make a determination as quickly as possible. There is no question about whether the drug will ultimately be covered. It may be that they have to change the diagnostic code. So, or it may be that the patient doesn't meet the requirement for the diagnostic code, so it's not covered for that particular usage, but it's still a covered drug under the formulary. Next slide, please. So Kaiser Washington, as I indicated earlier, Kaiser has its own pharmacies. So, Tom's question about I go to the pharmacy may depend on which pharmacy you go to. But there are some pharmacies that are currently being used that are out of network for Kaiser, or would become out of network for Kaiser, because for Medicare, they have specific pharmacies that they have to utilize. But there are similarly located in-network pharmacies. The closest one is 1.8 miles from the Bartels in Tacoma. The furthest one is 12 miles from the Rite Aid in Kingston. So within that range, they can find an alternative pharmacy. And again, mail order is always a possibility.
And Ellen, this represents our understanding of the full scope of network switches or pharmacies that would go out of network. So it's not like this is the top 10, I'm counting fast up. This is the totality.
This is the totality as it stands today. However, given the volatility in the pharmacy market and bankruptcies, et cetera, I don't know what's going to happen. Okay. So moving into the communication plan, as you know, OE is October 28th to November 25th. I will use this opportunity to remind everybody, especially in the Medicare space, forms must be received by HCA by November 25th. There will be direct communication from Kaiser and HCA prior to open enrollment to notify impacted members. So they'll learn about the service area difference, and they will learn about the drug coverage changes. There'll be specific letters that go out. There'll be articles in our newsletters. Next slide. We'll have updates on the web. We are using very actively the retiree engagement page. And so there'll be, articles or items there specifically targeted to Kaiser Medicare members. And then we've created a centralized email inbox. So similar to the UMP Questions 2024 inbox, which is very heavily used, I'm pleased to report. We've created KP questions at hca.wa.gov so that people can have a targeted place to send their email questions. They can ask specific questions, and it helps us collect and respond to member inquiries. And with that, are there any questions?
Remember, this is the benefit side, so I'm alert of that, describing kind of the embodiment of changes. And after we pass out lunch, Molly will go through the rate impacts of this the potential switch from MA to MEP.
Any additional questions for Ellen? Ellen, thank you so much. Appreciate it. All right, we're gonna take a couple minutes, break for lunch and working lunch, right? Okay, and then Molly will come and talk to us.
Why don't we plan to have Molly come up and start at around noon?
Perfect. See you at noon.
Do that? Yes.
I did that for Dave's sake, but it was unnecessary.
What's unnecessary? Okay, we're back. Folks got their lunches and now we have Molly Christie. She's the fiscal analyst in the FSD division and is going to be introducing the 2025 PEB program Medicare premiums that are going to be up for vote at our next meeting on July 11th. No action is scheduled for resolution today. Her materials are behind tab number 10. Welcome, Molly.
Thank you, Chair McDermott, members of the board. I'm pleased to be here, and we will move to slide 2. So first I'll share a few major updates before I get into the details. So I am very excited to finally bring the board the US Classic Medicare rates with Part D as we projected in the 2023 legislative report and shared with the board earlier this year. The 2025 bid rate for UMP with Part D is coming in at approximately $250 less than if the plan had retained creditable drug coverage. So this actually exceeds what we had projected last year. We've been talking about $200, and this is more than that. And it equates to almost $80 in monthly retiree premium savings compared to this year's premium. So compared to 2024, next year members will save $80 per month, which is very significant. Additionally, Ellen covered in depth both the Kaiser Washington and Kaiser Northwest proposals to transition to Part D prescription drug coverage under their existing PEB Medicare plans. So as she mentioned, this would represent no change to the medical benefit for either plan. And the rates that I have in this presentation today that are being proposed for 2025 reflect the Part D benefit for Kaiser Washington and Kaiser Northwest as well. And this, as you'll see, will result in premium savings for retirees in those plans.
And Molly, I just wanted to say real quick, it's been a long time coming. Watching those increases year after year, and especially when specialty drugs took off, and just watching the retirees get hit over and over and over again when they get their small COLA, and then we jump on with a big, huge rate increase. So just wanted to acknowledge the moment. It's been a long time coming. Appreciate all the work staff have done on this for working with folks to make it happen.
Thank you so much for, please have good news for.
Yeah. I was thinking the same thing as I was driving in today, that this is the first time we've publicly released Medicare rates in 3 years that have been good, that has represented good news. Yeah. Really good.
So I'm going to show a brief enrollment summary just so you can see in 2024 kind of current status of where members have landed. So in the 23 to 24 open enrollment, there was further shift in enrollment out of UMP. So UMP lost about 16% of subscribers, but it still has the highest member enrollment of all plans in the PEB Medicare portfolio. A lot of those members moved to United and Primera, so both of those plans had significant increases in enrollment. For the United plans, it was about 36% in that PEB complete plan on a subscriber level, and then about 19% increase for the balance plan, and then the Primera Plan G, which is the supplement plan that's open to new enrollment, increased by about 15%. The Kaiser plans held relatively steady, so there is not a lot to report there. And then the next section, I'm going to share the proposed Medicare premiums for 2025. This table shows the 2025 proposed single subscriber Medicare retiree premiums after the explicit subsidy, as well as the percentage and dollar change compared to 2024. These premiums also include the benefit changes Ellen described, so I won't discuss those in detail in this presentation. But again, I want to reiterate that the Kaiser premiums include the transition to a Part D pharmacy benefit. And you see that I'll start with kind of the bad news and then move to the good news. So the premiums are increasing for United and Primera by about 13%. And for Primera, I'm looking specifically at the plans F and G for members enrolled in Medicare due to age. So those are the members that are 65 or older. And the carriers did share some information about why we're seeing this rate increase. It's for several reasons, primarily high medical and pharmacy utilization for the Primera supplement plans. And then there were changes in the past year and then future changes to federal regulation pertaining to Medicare Advantage and Part D plans that have affected United. And that's why we're seeing an increase there. Alternatively, UMP and the Kaiser plans are experiencing premium decreases over 2024, and this is due entirely to the transition from creditable drug coverage to Part D. So as I mentioned, UMP premiums are going down by about $80, and that's 15%, whereas Kaiser Northwest is seeing a $23 decrease, and Kaiser Washington is seeing an $11 decrease per subscriber per member per month. This next slide shows the same monthly single subscriber premiums as well as the monthly subscriber and spouse or state registered domestic partner premiums. So here we're talking about 2 Medicare eligible members, and it's very simple. The monthly premium is 2 times the single subscriber premium. We do have a lot of subscribers who enroll a spouse, so this is helpful for those members to see what they would be paying per month. Great. And on the next slide, we have the value of the Medicare explicit subsidy by plan, which is calculated based on each plan's bid rate. The proposed subsidy for 2025 is $183 or 50% of the bid rate, whichever is less. As a reminder, the bid rate is essentially the total monthly premium before the Medicare explicit subsidy is applied. And what we refer to as the premium or the member premium is the amount that retirees pay per month for coverage. In other words, the retiree premium is the total bid rate minus the subsidy. You also see the term deposit rate listed in the table, which is just the bid rate plus the HCA self-pay administrative fee, which is usually between $5 to $6. You see it's $5.70 for 2025. This table also has 3 plans now at the subsidy cap. This has changed a little bit since last year, so I'll walk through it. These are UMP is still at that $183 cap. And then the Primera supplement plans F and G for members who are enrolled in Medicare due to disability. You might remember from last year that Kaiser Northwest is at the subsidy cap for 2024. So this year they're at the 183 cap, and Kaiser Washington was just less than $1 below that cap. But due to the intended transition to Part D and that premium decrease, both the Kaiser plans will be below the cap for 2025, which is great for members because if there are future rate increases, it is cushioned a little bit by that 50%. Right, and then next I will move into detail on the development of the UMP Classic Medicare bid rate with Part D. And this is a reminder that UMP is a self-insured plan that coordinates coverage with traditional Medicare for the medical benefit, which is administered by Regents. And as Jenny presented in the last meeting, Moda Health administers the prescription drug benefit. As a self-insured plan, the HCA sets rates in consultation with contracted actuaries at Milliman. So that's the team that I work on. We work with Milliman to set the rates that you see today for UMP. And the goal of this annual process is to set rates and resulting premiums based on the required cost to pay claims and administer the plan. So additionally, as a self-insured plan, we only retain enough to cover actual costs to administer the plan, including reserves. There is no profit margin. This means that changes in the rates that you see are really reflective of changes in healthcare costs, utilization trends, benefits. The big change you're seeing today is that change in the Part D benefit. And I wanted to provide some additional detail on the rate bill to help clarify the difference between the $250 in bid rate savings and the $80 in premium savings, because it's a little confusing why there are two numbers. And really, this comes down to comparing rates within a single year versus across years, plus the influence of the explicit subsidy. So this table compares the 2025 rates for UMP Classic Medicare with creditable drug coverage on the left to UMP with Part D on the right. So on the left is what retirees in UMP would pay in 2025 if the board had not approved the change to Part D. The right is what they will pay instead with the change to Part D. So I'll walk you through this. We see there's a difference of about $251 between the two 2025 bid rates. Creditable coverage again on the left and Part D on the right. And if we subtract the Medicare explicit subsidy, which is $183 for both of these scenarios, this results in the 2025 proposed premiums outlined in bold. So just over $700 for the current benefit with creditable drug coverage versus about $450 for the future benefit with Part D. And I really want to drive this home. If we compare these premiums to 2024, what members are paying today, that's the $532.94. If we had not made a change to UMP, the premium would have gone up by $171 or 32%. So members would be paying almost $704 per month. Instead, they will be paying $453 per month for a 15% decrease in their premium.
And get the benefit of the truth and get the benefit of some cost shares for specific drugs at a lower point and all of the protective measures of the Inflation Reduction Act. There's a lot of good news within this, and the reasons that the board agreed with our kind of the idea of moving to a Part D. So this is just icing on the cake.
So question, in future years, as drug costs go up, will we be experiencing with the Part D the same level of increase? Or is it muted in certain ways? And so we won't be experiencing an increase as quick as we would if we had not done anything. Is that clear?
Yeah, I mean, I think there is, participating in a federal program like Part D does provide some measure of protection. It does still come down to utilization and to formulary management and the things that we have MOTA do for us to administer the benefit.
But there are some dampening effects.
But there's significant dampening, yeah.
Okay.
Yeah, so I mean, I think that's the hope. I don't think we feel done with UMP Medicare, right? This isn't just we've made this change and we're just gonna let it ride. We're always looking at ways where we can kind of make the positive impact for members. So yeah.
Understood. Thank you.
So let's move on to the next slide. This is this chart tells a similar story, but it's looking at the UMP rate build up from 2024 to 2025. So the way we build the rate is we start with last year's rate, and then we adjust it based on claims experience, trend, benefit changes, other factors. Those are the little, this is called a waterfall chart. So those are the little boxes that you see. So we use an historical base period to set future rates. For 2025. We're using actual 2023 claims experience, and then we have to trend it forward 2 years. So starting with the 2024 composite bid rate of $716, the rate increased due to actual and projected claims experience, positive medical and prescription drug trends, continued enrollment shift out of UMP, benefit changes that Ellen discussed, and then higher pharmacy administrative costs for Part D. So all of those dark blue boxes represent increases over the 2024 bid rate. But in the light green, you see the major decrease due to that conversion from creditable drug coverage to Part D. So that's where we're realizing the majority of our savings. And then next, I want to walk through a similar comparison of the Kaiser proposed 2025 rates for their current plans with creditable drug coverage to help illustrate why we are bringing the proposal for the Kaiser plans with Part D today. So this is similar to what you saw for UMP. This table compares the 2025 rates for Kaiser Washington Medicare Advantage with creditable drug coverage on the left to the same Medicare Advantage plan but with Part D on the right. So on the left is what retirees in Kaiser Washington would pay in 2025 under the current benefit, and the right is what they will pay instead if the board approves the rate for the plan with Part D drug coverage. So you see here that there's a difference of about $116 between the two 2025 bid rates for creditable coverage versus Part D. And if we take that down, so we subtract the Medicare subsidy, that results in the 2025 proposed premiums outlined and in bold. So that's $282 for the current benefit with creditable drug coverage versus about $177 for the future benefit with Part D. And we're not really, I mean, it is useful to compare those two premiums, but we're comparing year over year to the premium you see in 2024, which was $188.62. And so if we compare the status quo plan, the current benefit with creditable drug coverage, the premium would be increasing by $93 per month or 50%. So that means that if the pharmacy benefit does not change to Part D, members will pay almost $100 more per month for the Kaiser Washington Medicare premium. In contrast, the future proposed plan with Part D, that is also this is what we are proposing for 2025, would have a premium decrease of $11 compared to 2024. And I'll walk through the same illustration on the next slide for Kaiser Northwest. So again, you have their existing senior advantage plan on the left, that's with creditable drug coverage. And then you have their proposed senior advantage plan with Part D drug coverage on the right. The difference in those bid rates is about $74, subtracting the Medicare explicit subsidy. As I mentioned, they were at the cap for 2024, but they'll be below the cap for 2025 with that Part D plan. Gives you a premium of $227.85 for the current existing benefit versus $171.19 for the proposed benefit with Part D. That's an increase compared to 2024 of almost $34 if we make no changes to the plan versus a decrease in monthly premium of about $23 if the board approves that change to Part D. And so, you know, when we were discussing in about how we propose this to the board, the significant rate increases for the current Medicare plans was really a major factor in bringing the Part D proposal forward for 2025. And then additionally, Ellen really showed that similar to what we're doing with UMP, the Part D transition has limited member impacts and some additional member benefits just within the benefit design based on how members use their prescription drug benefit. And all members would benefit from lower monthly premiums. So it made sense to bring this to the board for 2025. And I want to make sure that everyone understands that the rates proposed represent the plans with Part D prescription drug coverage for UMP, of course, because the board has already approved that change, but for Kaiser Northwest and Kaiser Washington as well.
I'll also add, this board season was also a really good time to have this conversation about the Kaiser plans because we had just had a very similar conversation for several months about UMP. If we had not had that conversation for UMP and we were suddenly coming to you, and more importantly, I think the public and retirees who are paying attention to the board meeting, that this would presumably come out of left field. We'd be talking about it today and asking for you to vote on it in 2 weeks. But in the context of having had a multi-month conversation about some of those benefit design, protective measures, and the logic that we went through on UMP, much of the logic is the same, the value of those levers is different in UMP than in Kaiser, but the principles are fairly similar. And so it didn't feel to us that this would be seemingly rushed from the public perspective, because it really does piggyback off of a lot of the conversation that we've been having under the UMP conversation. And showing the rate differential, we thought would further help cement understanding of why this idea is coming up across the portfolio essentially in the same year.
Are there any questions from the board before I move on into the proposed resolutions?
Yeah. I have one. Oops, hello?
You're good. Come on, John. Oh, Tom.
Oh, okay. Could you go back to slide 11, please, for just a moment? Okay, so I want to make sure I understand this correctly. Had we not done anything, had we remained with our coordination of benefits, we would have seen a $171.03 increase in single subscriber premiums. Is that correct? 32% increase. Now, I think this might have echo a question that Lou just asked a little bit ago, but I want to make sure I understand it. If we now we've moved to Plan D, but are we going to have to anticipate that next year, if we're seeing these kind of increases every year of between $130 and $170, which I think if you go back and look for the last 4 years, that's about the amount every year that we've increased. Are we going to still be stuck in that same rut of seeing another significant increase, so that after only 1 year, people are again going to see their rates go up? Or are there other mitigating circumstances that we are not yet taking into account that might make it possible that some of those rate increases might not be there?
That's a great question, and it's something that's been on my mind as well. And part of the answer to that is we have to see how the rest of 2024 plays out. We will use 2024 base experience to project 2026 premiums. Again, as I said, I think we have some protection on the pharmacy side participating in Part D. But if you look at slide 12, we do still have positive trend both for medical and pharmacy. That means costs are increasing due to inflation as well as utilization. And, you know, we don't know what the enrollment shift will look like. The premiums for UMP are still higher than for similar plans in the portfolio. Not necessarily equivalent to members, right? Because the way that they value their plan can be different based on their needs. But we don't know what that's going to look like. So as I said, I don't think we're done with UMP. I think we still have some levers to help mitigate future rate increases. I don't anticipate for 2026 seeing an increase of the magnitude that we would have seen for 2025 had we not changed. So I don't anticipate something in the realm of $100 to $200 in premium. But I can't say for certain what it will look like.
Okay, thank you.
I think an important thing that Molly said is there are a potential couple other levers that we can bring to the board to pull that might be able to be used to offset an increase in an individual, like one-time levers to pull to help mitigate a premium increase in a future year. As far as I know, none of them are as valuable as the one the board pulled this year. So there are other pieces that we'll be looking at to be able to bring you to say, let's say that there is a year where it looks like it's a bigger increase. We say, similar to what we did with the sub board last year, with the Kaiser increases, their Kaiser increases could have been even more if the sub board hadn't pulled a lever to standardize some of the benefits that were richer in the sub portfolio than much of Kaiser's other book of business. So they dampened the effect of that by pulling that lever. We have a couple of levers that we could bring you to consider, but they aren't as valuable as the one pulled this year.
I'd like to ask a question. If I can go back to slide 12. It piggybacks off of what Tom was asking, I think, or maybe helps understand it a little bit better for me anyway. Which is if we take the change in claims experience and the medical part of the medical and RX trends, do you know percentage wise, I don't know if that's the right way to ask it, but of what would have been the increases, how much of it was tied to the medical?
Mm.
You know, we know that the medical is 35% or therefore, but you know, did it go up 5% or 10%? So I think we have to kind of assume following year it's not going to go down.
Mhm.
But it would give us some notion, I think, of what the medical part might be.
That's a good question, and I can definitely bring that back. What I can say is that in our projections, so historically, we've always said pharmacy in Medicare is like 60% of our claim spend, which is significant. It's not anywhere near that for non-Medicare. And that's because we have a COB plan, so a lot of those medical costs are being offset by Medicare as the primary payer. With this change to Part D, that 60% pharmacy is going down to like 40% or around 42%. So it's taking up a bigger piece of that pie. But I think what you're asking about more so is medical trend.
Yeah, because I think medical trend gives us some sense of what might happen on the medical side. Prescription drugs got to play itself out.
Yeah.
But, you know, medical trend we've had for 40, 50 years.
Right, and it's significantly less volatile than pharmacy. It's historically stayed relatively stable. There was some upset with COVID and following COVID, certainly, but that's not where we're seeing. It's a positive trend every year, but it's not where we're seeing these significant increases.
Yeah, and I think that's kind of where I'm trying to get to, is I think from that point we feel relatively safe. So it's going to come back once again to the prescription drugs. It's going to be the driver.
Yeah, I see what you're saying, definitely.
This may be a risky thing to say, but given changes in the United States and laws that may happen, there's no way for the board or for HCA to predict what a new federal administration might do to the Medicare system. And it might not matter if we went to Plan D or not, or if it was UMP, may affect all the plans. I think this has not been a predictable year with events, and it may apply to federal legislation as well next year.
And I think that's one of the reasons why we're all full-time employed at HCA. We're monitoring these things at all times, the litigation, the federal regulations, the legislature, all these things get taken into account in our processes. And then we try and determine, okay, what do we have to respond right now? Does it happen in the next rate season? How does it all go? So if anything catastrophic were to happen with rules and stuff were to happen out of cycle, I would imagine the board would be reconvened to address the issue, to talk about it. This huge thing has happened and now we have to do X, Y, Z. So yeah, it's an everyday thing.
And to your point, Elliot, I mean, we all know that there's been, a decade now of debate about the Affordable Care Act. And the significant debate, policy debate on different sides about the Inflation Reduction Act. And a lot of the things that we've described are benefits of things that are under the Inflation Reduction Act. That's the Medicare negotiated pricing. So there are things that are inherent in the Inflation Reduction Act that, to the extent that is a piece of legislation that is focused on by different parts of or different members of Congress on federally is something to be watchful for. I mean, there's certainly vigorous debate from a policy perspective at the federal level about the merits of the IRA. And I'm not chiming in on those debates, but just saying, acknowledging that there is. And so just like there were many questions about the long-term sustainability of the ACA being enacted law federally, which after a decade seems fairly settled at this point, but not for, nothing's, to our point earlier, nothing is ever really permanent, is it? There's a similar kind of phenomenon that very well could manifest over a period of years about the Inflation Reduction Act. And that is there are a lot of pieces of this component in moving to Part D that are related to bootstrapping to the IRA. So, as Lou said, we're full-time employees here at the Healthcare Authority. Any other questions before moving on to the resolution? So,
Don, do you have your hand? Did you have your hand up?
I did. Elliot said exactly what I was going to say. From a 30,000-foot perspective, we have no control over a lot that's going on. And like HCA, I spent a lot of time looking at what's going on in the policy arena of the both political parties. And there's such a different view of healthcare, particularly Medicare, within the two parties. That I think that we're going to have a busy 2025 season.
Thank you.
Okay, so the next slides introduce the proposed PEB Medicare premium resolutions. Just as a reminder, when we ask the board to vote on the premium resolutions in July, you'll be asked to vote per carrier. That adopts all of the Medicare plans offered by that carrier, as well as the premiums and the benefit design underlying those premiums that Ellen discussed. So those benefit changes, all of that is factored in. This proposed resolution would set the Medicare explicit subsidy at the cap that was set and funded by the legislature for 2025, which is $183 or 50% of the premium, whichever is less. I have to say to you, the board, that you have the authority to set a lower subsidy amount. So this is where that could be done if you so choose. I will draft the slide with
maximum authority. If you want, we could practice parliamentary procedure, put a different number in, and then somebody could move to raise it. But we'll just skip all that. We could just cut to the chase.
Right, next slide. This proposed resolution adopts the Kaiser Northwest Medicare premium. The next one is for Kaiser Washington. I'm just gonna fly through these. The next is for United Healthcare Medicare plan premiums. And then we have Medicare Supplement by Primera. And then finally, UMP Classic Medicare with Part D. And that concludes my presentation.
Do you have any questions or comments from Molly? Molly, thank you so much.
Thank you.
Must feel a lot better to be on that seat with the.
I feel great.
Yeah, you're like.
So pleased. Yeah, it was a good day.
Awesome. Appreciate it. Dave, I think you're gonna go over the rest of the weekend, 2025 board schedule.
Yeah, 2021 apparently. 2025 begins today, turns out. So as we end the board season or get near the finish line, we do publish the schedule for the next board season. It does have to be filed with the code revisor's office, so we set our regular scheduled meetings under the Open Public Meetings Act. But we like to bring kind of the intended schedule and start sharing it with the board and the public in the next to last meeting of the board season, and then finalize it and publish it in time for the final board meeting of the season. So a couple of features to highlight here. There's a general theme that try to follow to have as predictable a schedule as possible, but then there are some reasons to vary from that. So we typically have the board retreat at the second half of January. It's usually we focus on Thursdays so that everybody knows on Thursdays we have board meetings. So there's board meetings, it's Thursdays. At least that's the way it is for PEB. Because we like to have that predictable schedule and not have a point in the schedule where we are shifting days of the week because we know a lot of retirees are attending meetings and we don't want them to show up on the wrong day. So it's on Thursdays. So we see the retreat this year is actually still in January. This year we had crept into February because of the way the calendar falls, but we're back to the very end of January. You might remember or feel that the March meeting schedule is earlier than it has been this year. And if you did have that sense, you are correct that this schedule moves that back up. We had frame shifted later into March because of how the short session end date was ending on a Thursday, and we didn't want to have All of us here at HCA, it's either a really busy day or a completely not busy day from a legislative standpoint. On the last day of session, we didn't want to have a board meeting of either board on the last day of session. So we had pushed March out. Now we're going back to the goal is for March, April, May, and June to have the first board meeting of the month for PEB be the second Thursday of the month. And so we're back to kind of that. Except then you look in May and you're like, hey, May 15th feels a little later than usual. That's because of the way legislative session ends this year. The legislative session for the long session is almost one of the latest it can possibly be from a calendar standpoint. It goes to April 27th, I believe. And so the first Thursday of the month, we usually do SEB, and the second Thursday of the month, we do PEB. But May 1st is too close to April 27th to be able to really turn things. We also noticed when we do our rate procurement process, Beth highlighted, we release things in late February, early March. We get a lot of info that comes in on May 1st. And we wanted to just kind of push the schedule a little so that we had a higher chance of being able to share things with both boards in the executive session in May. So May is a little later than you might kind of naturally feel. You're not imagining that. In June, again, we always have 2 meetings in June. Our goal is to try to do as much of the rate development process and get to public rates at the end of June if possible. We've been able to hit that for Medicare consistently over the years. We've needed more time historically on the non-Medicare rates. However, this year we were able to expedite things because of the nature of the negotiations. There were just some dynamics that we were able to actually meet that goal of trying to get it done at the end of June. And then in July, we always schedule a meeting every week in July. We're not going to have a meeting every week in July. I don't think we've ever had a meeting every week in July of a single board. I think we've had 3. I don't know if we ever had 4, but we're not sure exactly. And we want the flexibility depending on how rate negotiations are going. We'll always have at least 1 because this year we're going to have 1 on July 11th. We usually have 2 that are staggered somewhere between the beginning and end of the month. We've rarely had 3. And once in a while, we've even had spill into August. But we like to overschedule July and ask you to hold those times in case we need those. So that's generally what the schedule looks like. And that's what I have to share. Mark your calendars.
And here we go. All right, we're at, anybody have any questions or concerns? Okay, excellent. We're at public comment. Anybody in the room? Seeing none. How about out of the Zoom end? If you are a member of the public and you'd like to raise your hand, your Zoom hand, we'll go ahead and call on you and you have an opportunity to speak with the board. Amy? Amy, you're up.
Yes. Good afternoon, members of the board. Chair McDermott. Thank you for the presentations that we've seen the last several months. It's been a lot of material, but useful. And seeing the rate today for the uniform classic Medicare with Part D, I'm wondering if for the vote, it would be useful to show exactly what the full benefit cost will be, including dental, vision, and hearing, just so that it's clear. This is not everything. So if that, as I understand it, so I find that would be helpful. And then a second area, maybe for concentration for next year, is rural healthcare. It's with some dismay to see less and less service on the other side of the mountains and also in smaller communities. And I'm wondering what might be some options that rural communities can start working with, and if someone in the healthcare authority is assigned to do that work. Thank you.
Thank you, Amy. Next up. Aruna?
Good afternoon.
Good afternoon.
I'm Aruna Bhuta from Spokane.
All right.
Thank you for this opportunity. My question was around Plan F and Plan G premiums going up because of Medicare Advantage requirements. I feel like Medicare Advantage plans and Medicare Supplement plans are separate entities altogether. And why would there be an impact on Medicare Supplement plans when there are some additional requirements on MA plans? Do we have any explanation?
We appreciate your comments, and we'll be taking a look at that, and we can respond to that at the next board.
Okay, can I ask another question?
Of course.
Okay. In Ellen's presentation in the earlier slide, she mentioned if the drug becomes non-covered, members are grandfathered for the remainder of the plan year, minimizing the impact. So there is a possibility that formulary changes can happen and some of the drugs are taken off as far as the coverage is concerned?
Oh, Runa, I think I can answer that one right now. That can happen today in any of the plans. Formulary changes, that's not you, I don't know that this is reassuring because it's the way all the plans work today and tomorrow under any of the proposals. And Molly's coming up and might be able to chime in too. That formulary changes really can happen at any time. They do happen on a regular basis. So I just want to at least reassure you that it's not unique to the proposals before the board for either UMP or Kaiser, but Molly's turned on her mic and she's going to chime in.
I wanted to address your first question, Runa. I apologize if I misspoke. So the Medicare Advantage, the federal regulations pertaining to Medicare Advantage are only affecting the Medicare Advantage rates like United. The Primera plans, they shared that their rates are increasing primarily due to changes in utilization. So the benefits that members are using both for medical.
Okay. Because of utilization. Okay. Thank you very much for clarifying that.
Certainly.
And I have one more question, if I may ask.
Okay, go ahead.
And Molly was presenting about, and also Ellen, about Kaiser Permanente 2 plans, KWNP and the other plan. If they remain as it is and if they change to Part D plan. So this Part D plan is going to be similar to the one that UMP, that HCA is adopting. Is that correct?
So two things on the pharmacy, Aruna, this is Ellen. One is on the changes that happened during the year. This happens currently under Part D plans and will continue to happen. If there is a change made at the federal level so that a drug becomes not covered under Part D, it is covered for the remainder of that plan year. So there are no mid-year eliminations of a drug, if you will. On the question.
And that'll only happen if the person is on UMP Part D plan, not if they are on a marketplace plan, Part D plan. Is that correct?
So it happens in any of the Part D plans in the PEB portfolio because all of those plans are employer group waiver plans. However, the grandfathering for the rest of the plan year, of that current plan year, that happens even in commercial plans. So the way that the commercial plans work is the same thing. If a drug ceases to be covered, if the federal government is not going to cover it in the following plan year, it is still covered for the remainder of the current plan year. As far as the question of, and I just forgot the question.
Kaiser Permanente,
the similarity
being a Medicare Advantage plan, they are already Part D plans. So are they being shifted?
Aruna, the Kaiser plans, both Kaiser Northwest and Kaiser Washington, those are currently Medicare Advantage plans. Today, those plans both have creditable drug coverage. They are not currently Part D plans. Under the proposal, each of those would become an MAPD, just like the United plans are MAPD. They'd be Medicare Advantage plans, including Part D prescription drug coverage. The formularies, however, you're welcome. The formularies, however, are different because each carrier is under a different federal contract with CMS and approves their formulary under their contracts with CMS. So there are slight differences. So it's not that people in Kaiser are getting the UMP Part D formulary.
Thank you, Ellen.
Thank you very much.
Thank you, everyone. Others?
Next, we have Sarah.
Sarah?
Good afternoon. I'm Sarah Cook. I'm a unit manager in forecast finance and managed care rates at HCA and am a UMP Classic PEB member. I would like to request an audit of the massage therapist provider network on UMP to determine how many practitioners are still active providers in the service area and accepting new patients, with the potential to increase the cap. The network looks adequate on a screen, but that has not been my experience. The only covered massage therapist I've been able to establish care with has to book out about 6 to 8 weeks in advance, and is actually planning to leave the profession when she completes her training as a midwife. I've not really been able to find other covered massage therapists in Olympia taking new patients, and I prefer to get my massage therapy taken care of at the same location as my chiropractor's office so that I have that continuity of care. I was interested in when Regent stopped accepting new providers in their network for massage therapy, and why there's so much trouble finding covered practitioners in Thurston County. It looks frequently massage therapists leave the profession sooner than other healthcare professions. According to a 2023 report by the Association of Bodywork and Massage Professionals, between 50 to 88% of massage therapists leave the field in 3 to 5 years. And given the above information, it would stand to reason that it's past time for UNC to do an audit of the massage therapy provider network to see what the actual adequacy is. While members appreciate the increased number of chiro massage visits we've gotten in UMP, it seems a bit of an empty gesture if the network adequacy to use the benefit isn't there. If I'm having this much trouble as a PEB member in Olympia, where there are a lot of PEB members, how much worse would it be for PEB members in less populated parts of the state? I think that if provider network is adequate, then I think we might need to add a tool provided by Regents to offer us a way to connect to available massage therapists, as it's been done in behavioral health. Thank you.
Thank you. And Dave, I wanted to verify that you got all that.
Yep. Actually, all the clarifying questions I was going to ask, Sarah gave answers along the way. So, yep, I definitely captured that. There was a little bit of audio issue, but I definitely captured everything that was there.
Perfect.
The summary that I got, just to make sure I did get it all, Sarah, is that it's about massage network access, starting in Thurston County, but also concerned about rural areas as well. The difference between network access on paper versus actual access, wait periods between massage therapists that are covered or in network, and then a question around what is the onboarding process, and if it has stopped, and if it stopped, why it stopped for additional massage therapists within the UP network. Did I capture all the high points?
Yes, thank you, Dave.
Yeah, thank you. So yes, it was successful.
Thank you. Mackenzie. John.
John, you're muted.
Yes, I want to just take a moment to thank Healthcare Authority staff and my voting colleagues for all the work they've done in developing and implementing all the changes that we've seen over the last 2 years, and particularly in managing the premiums. I think that's been a tremendous effort on their part to get the premiums to where they are. I just want to say thank you and recognize you for the work that you've done.
Thanks, John. I will take that appreciation for everyone here that's listening in the room, as well as those who aren't in the room but had a significant role in it to help the board get to that position. I do want to go back and at least answer a part of Amy Fortier's question that she asked at the beginning of public comment. I just want to clarify that the Medicare rates that Molly presented include medical, hearing, and vision. In the Medicare space, hearing aids, hearing coverage, and vision coverage is embedded within what we call the medical rate. So that rate does represent the totality of what people might think of as classic medical coverage, hearing coverage, and vision coverage, and pharmacy. So those are, Ellen came up and whispered in my ear, and pharmacy. The one that does have a separate premium is dental coverage. And we I think it came up in the non-Medicare space that we'll bring up the dental pieces and share where those rates are at the next board meeting. And then there's the question that we'll research about. We haven't voted on dental rates for retirees in a long time, just kind of like fact checking where we are on that and if that's something that needs to be done or not done. But I did want to clarify that the rates that Molly presented are the totality of medical, hearing, vision, and pharmacy. The only thing that's not included in that is the separate dental premium.
Thank you, Dave. And Ellen, thank you. Appreciate that. Just want to clarify that.
I didn't want that one to linger for 3 weeks.
There you go. Kenton, any other? All right, that concludes public comment. And it concludes this board meeting. Our next and last board meeting for the year will be July 11th, 2024, with the same format and attendance in person or via Zoom. Dave, any final comments before we break?
I'd like to do a preview of coming attractions. So on July 11th, we will bring back all the resolutions that were presented today for voting, both the non-Medicare premiums that Tanya brought, the Medicare premium, and supposed to be the resolution that Molly brought. We will have Ellen back again, to talk about how our Part D implementation is going. To just, we're not going to end the board season by not talking about the transition into open enrollment from our Medicare implementation. Alyssa will be here to talk about just the general transition and open enrollment experience, preview the benefit fare schedule, things of that nature. And then we will have a presentation about the PEB consolidation report that has been tasked with the agency. What we're really doing in that presentation is we're going to overview at a high level kind of where things are, the way we're thinking about the topics, providing insights, and really we're using the end board meetings on the 10th with SEB and the 11th with PEB to kick off kind of a month of stakeholdering. We want to level set, have the board to yourselves, our stakeholders, get your feedback, and then we're going to transition to having kind of a general session with a variety of stakeholders, carriers, labor leaders from PEB and SEB, benefits administrators from the PEB and SEB employers, healthcare advocates that are interested in a different system of insurance and coverage in our state, and kind of do a stakeholdering process with them, culminating in a request for written stakeholder feedback at a date in August. But we are kicking all of that off and wanted to end the board season with talking about where we are on that report that is due in December. And then I don't anticipate any changes to the 2025 schedule, but we'll say that it's signed, sealed, delivered, and filed.
Any final questions or thoughts for Dave? All right. Dave, thank you to you and your staff again. Outstanding. Big day. Thank you to board members for taking the time and all the thoughtful questions and comments. This meeting is adjourned.